Okay. So I believe the voice was working fine. So maybe we can. It's already 10:57. So maybe we can start the class at 11, or we'll have to wait for the students. Just have a look at the video, like because we I plan to use this PPT. So just see how does it, because I won't be able to see how does this appear on the screen. So let's see. Suppose if I keep the PPT like this, and is my face covering the? That's okay. I think that's perfect. Right, 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 right. It's perfect. Okay. Right. Kindly allow me to start. First, confirm me if I'm audible and the screen is visible. Someone of you please reply on Telegram. Right, 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 right. Great. Thank you. Akash ji, Dr. Ishita, Kritarth, Mohib Khan. Thank you. Yes. So today we'll be discussing the important questions in surgery. Fine. From yesterday's topic also, and from today's topic also. So I believe the pattern would be such. The pattern would be such that I'll ask you questions, and maybe, that's entirely up to you. Maybe you would like to reply me your answers on Telegram, right? Or maybe, many of you may be just mute spectators. That's perfectly okay. That's perfectly okay. It all depends upon your style of learning. Fine. So there are good number of questions. See, some of the questions are like that. They are just one liners, so we can easily pass by them. Some of the questions, they will require some detailed explanation. Fine. So we'll go by that only. We'll go by that only. Fine. But it's my humble request that for the first few questions, please reply. At least please reply. I believe, because after a while, maybe you guys get tired. But as of now, maybe you are fresh enough. Fine. Maybe you have just had your morning cup of coffee. So maybe you guys are fresh enough. Right. So this is how the pattern of the question would be. I forgot to switch my OneNote on. Just a second. And here we'll be writing the explanatory notes also. You already read from the best brains. So please try to answer this question. Question answer session is open now. Please try to answer this question. Then there are clinical scenario based questions also. There are few one liners also. This is a granny knot. Fine. So granny knot, what kind of granny knot is? It is an unstable knot. It is an unstable knot. Hi Lokesh, I like your DP. And pepper pots. What's so special about your DP? Your name also has got your DP. What kind of knot it is? Unstable. Why it is granny knot? You see here, the first throw and the second throw, they both are in opposite direction. They both are in opposite direction. See, this is a typical granny knot. So granny knot is kind of unstable knot. So where do we apply granny knot? Where we have to apply the stray suture. Where we have to apply the stray sutures. In between, I'll be asking more questions also. I'll be asking more questions also from that. Fine. Now, let's see about the other knot. Reef knot is similar to square knot. Is similar to square knot. Fine. Then the surgeon knot. One throw, second throw, followed by another throw. So that throw is a kind of locking throw. Locking throw. Fine. That's a simple knot. This is a granny knot again. And this is a half hitch knot. Half hitch knot. Now this is Miller knot. Now Miller knot is used for packaging. It is generally not used in surgery. This is just used for packaging. You must be getting to see this at Kirana stores and all these kind of things. Miller knot. So never get confused by these things. Examiner may ask you some of these things also. Fine. Miller knot. At the shopping malls, at the Kirana stores, you'll get to see this knot. Find the Miller knot. That's a way how to tie a Miller's knot. Right. But this is not important by our point of view. Only thing is because it was asked in the question. So I'll have to give some kind of explanation about this. Right. Now, so you have to identify the suture. You have to identify the suture. Come on, I'm waiting for your answers. No. Oh God. The options are not correctly chosen. I'm really sorry. The options are not correct over here. The options are not correct over here. I'm really sorry. The options are not correct over here. Now can you check the right answer? Now can you check the right answer? Basically, why did I want you to solve this question? Why did I want you to solve this question? I'm really sorry. The options are not correct. The options are not correct. So what is polypropylene? What is polypropylene? Polypropylene is synthetic monofilament suture. Because it is synthetic, because it is monofilament, fine. So it will cause least irritation to the skin. That is why it is preferred in the suturing of skin. That is why it is preferred in suturing of the skin. Fine. Now, How did I want you to identify? I wanted you to identify it by the packaging color. I wanted you to identify it by the packaging color. Fine. Now you see here, polypropylene. It is, the packaging is royal blue. Let's have the packaging colors. Fine. See here, the suture packaging colors. The plain gut, the cover will be yellow. Chromic catgut, the cover will be brown. Silk, the cover will be light blue. Fine. And nylon. This is what was asked in the question, and I could not frame the question correctly. My regrets. So, nylon is also known as polyamide. Polyamide. Fine. Nylon is also known as polyamide. Fine. Vicryl. See, those of you who answered it as vicryl, fine, that is totally wrong. Those of you who answered it as vicryl, see, vicryl is polygalactin. Now, even if the color coding question was not correct, it clearly says that it is a non-absorbable suture. It is a non-absorbable suture. Fine. Now, if we go by the question, you see, polypropylene is non-absorbable. Silk is non-absorbable. Polygalactin is vicryl. Catgut, fine. So they both are absorbable suture. They both are absorbable sutures. Fine. So this could not have been polygalactin. This could not have been catgut. Fine. So this could either be, polypropylene, and this option was supposed to be polyamide. This option was supposed to be polyamide. Now, because the packaging color is green, fine, that is why this is polyamide. That is why this is polyamide. Fine. So this suture is polyamide. Why? Because the packaging color is green. I don't know why we have to reach this thing, but your examiner has gone saddest, and he is asking such kind of questions only. Such kind of questions only. Fine. Now, can I ask another question? Can I ask another question here? You see the sutures, which are names which are written on the screen. Fine. I'll write that this is about absorbable, this is absorbable. Fine. This is absorbable, this is absorbable. Which of the suture will stay in the tissue for longest period of time? Which of the suture will stay in the tissue for longest period of time? Please answer this question. Which of the suture will stay in the tissue for longest period of time? Let's name them. So you just have to answer 1, 2, 3 or 4. Dr. Priyadarshini, Dr. Akash, you are trying to answer. But I am talking about the absorbable suture. I am talking about the absorbable suture. You have to answer between 1, 2, 3 and 4. Which of the suture will remain in the tissue for longest period of time? Only amongst the absorbable sutures. Yes, Dr. Devman finally gave the correct answer. Dr. Devman finally gave the correct answer. See, plain catgut will be absorbed in 3 to 7 days. Fine. Chromic catgut will be absorbed in 30 to 90 days. Fine. Vicryl will be absorbed in around 90 days. It is the PDS, polydioxanone silicate, which will be absorbed in 180 days. Which will be absorbed in 180 days. So this remains in the tissue for the longest period of time. Remains in the tissue for the longest period of time. Fine. Now, what is the other benefit of polydioxanone? Polydioxanone. So this has got least affinity for E. coli, which has got maximum affinity, for E. coli. Which suture has got maximum affinity for E. coli? That is Dexon. Dexon has got maximum affinity for E. coli. Dexon. has maximum affinity for E. coli. This you must remember always. This you must remember always. Now, I just read a question somewhere. I just read a question somewhere. Please try to answer this question. Which suture should not be used in the infected tissue? Which suture should not be used in the infected tissue? Anyone, please? I'll give you the options. Proline, catgut, vicryl, nylon. Which of the sutures should not be used in the infected tissue? Which of the suture should not be used in the infected tissue? Dr. Antioxidant, may I please know your real name, brother? Abhinav, yeah. So yesterday probably I also told you that one of the best residents of mine, one of the best resident doctor of mine is also called Dr. Abhinav Pandey. No, no, no. Why are you giving the wrong answer here? See, let's go something, let's dive something literally. Let's dive something literally. What is catgut made up of? Catgut is made up of sheep intestine. Fine. Which part of the sheep intestine? Submucosa. Fine. Now, if we take the cattle, then it is made up of serosa. Fine. So, submucosa is rich in collagen. So, basically, if we think of, I know it is very gross and it is not very good to talk about in the surgery class, but at the end of the day, intestine, submucosa, this all is nothing but meat. The meat which we eat, I don't eat. Fine. So the meat cannot be kept where the infection is. Bacteria will immediately digest the meat. Before the body digests it, bacteria will immediately digest the meat. So catgut should never be used in the infected tissue. Catgut should never be used if the tissue is infected. Yes, right? So proline can be used because this is monofilament. So this can be used. Fine. If required, vicryl can also be used. If required, nylon can also be used, but this should never be used. This should never be used. Yes. Okay. Why catgut is an irritant suture? Why catgut is an irritant suture? Fine. First, it is stored in isopropyl alcohol. It is stored in isopropyl alcohol. Second, because this is a natural suture. Because this is a natural suture. So any kind of natural suture is going to be irritant. Any kind of natural suture is going to be irritant. Fine. That is it. That is it about the. Yes, 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 exactly. Fine. So you just need to remember the color. My request is remember at least these colors. See, I tell you how to remember this. I tell you how to remember this. When you're done with your exam and you will join us as interns, this suture you will commonly use. Fine. Though it is not very good recommended, but this you will commonly use for suturing the skin. So this you should remember. Fine. Now, this suture you will use over the face because it will give best cosmetic result. It will give best cosmetic results. Fine. This suture you will use when you are suturing back the abdomen. Suturing back the abdomen. Now vicryl, you know, it is called as workhorse suture. You can use this suture anywhere. You can use this suture anywhere. Fine. Now again, you know, for us, you are our kids. I mean, we really love you guys, but then your examiner doesn't love you because, you know, apart from suture packaging color, he may ask you this question also. That what about the suture material? Suture material also has got a different color. Suture material also has got a different color. Fine. See, for catgut, it is the same. Packaging color is same. Even the suture material color is also same. Fine. For prolin, both are same. Fine. Silk is different. Silk, the packet color was light blue. Fine. And the material color is black. Fine. Vicryl, V for vicryl, V for violet. Cotton, there's a mnemonic also. Cotton is always white. Cotton is always white. Fine. So this is how you need to remember this. This is how you need to remember this. This PPT also has got some of the explanatory notes also along. So I'll share this PPT while we're done with the lecture. Right. We move to the next question there. Yes. Oh God. Which of the following needle will you use to suture a laceration of the liver? Which of the following needle you will use? Just read this question, then I will scroll through the slides. So there are three images below. There are three images below. Fine. So once you have done reading this question, I'll wait for 10 seconds, then I'll move over to the next slides. So you have to choose which of the needles you will use to suture the laceration of the liver. So if the liver is lacerated, right, we move forward. Will you be using the needle marked as A? Just have a look at the three images, then answer please. Then answer. Karan, wait. Karan is like, Karan Blow, you're not replying to your girlfriend over here. I mean, you're so quick actually. It's not about the circle. It's not about the circle. Will you be using the suture B, suture needle B? Or will you be using the suture needle C? Yes, now you can answer. Now you can answer. So let me get it correct here. So this is a taper point needle. You can see the taper point. You can see the taper point. Fine, taper point. And then it ultimately becomes round body. It ultimately becomes round body. Fine. So this will be used for slightly hard tissue. We can actually call that as firm. We can actually call that as firm. Fine. Not the skin and periosteum, but the firm tissue. See, the problem is that liver is a friable tissue. Liver is a friable tissue. So for that, you have to use blunt tip needle. You have to use blunt tip needle. So this is the correct answer. This is the correct answer. You see the tip of the needle. This is blunt. This is blunt. For example, Karan answered it as a circular needle. I'll tell you about that point also. Yes, Dr. Rishabh, it is a delicate structure. Fine. So we should be using the blunt tip needle. We should be using the blunt tip needle. Fine. Now you see here. Can you see there is a cutting edge on the outside? There is a cutting edge on the outside. So what should be the logo for this? Logo for this should be inverted triangle. Why? Because this is a reverse cutting needle. This is a reverse cutting needle. So this needle is ideal for suturing the skin. This needle is ideal for suturing the skin and other cornified tissue. Other cornified tissue. Fine. So this is basically a reverse cutting needle. Reverse cutting needle. Now, yes, for tough structure. Tough structure, periosteum, skin, all these tough structure. Now you see here. For example, Karan answered that we should be using the circular needle. We should. What did the Karan, our friend Karan answer? Karan said that we should be using circular needle. See, the needles are like this. Can I open my PPT here? I think I can. So what kind of suture is this? Because we have opened this PPT, so let's just spend 2-3 minutes over here. Let's spend 2-3 minutes over here. So what is this? This is a barbed suture. Barbed suture. Barbed. You see, barbed. There are spicules over there. So this is used for not less suturing. This is used for not less suturing. Fine. Not less and intra corporeal. That means when you are inside the body, while you are doing laparoscopic surgery, fine, then you use this kind of suture, fine, barbed suture, fine. So barbed, you see there are multiple anchoring points, fine. So this is the suture which is used for knotless suturing, fine. Now coming to that, see, so Karan was talking about this, that we should be using the circular needle. See, I'll write it over here or write it over here only. If the operating space is narrow, for example, you are operating inside a narrow body cavity, then maximum curvature needle is to be used. Maximum curvature needle is to be used. I mean, the needle should be maximum curved. Maximum curved. Fine. For example, you are inside intestine. You are deep inside the abdomen. You have a very narrow space. You performed laparoscopic cholecystectomy, and you are about to suture the fascia. See, the incision length would be this small, and you have to go deep inside this incision. So the operating space is very narrow. So you will use this needle. You will use this needle, 5/8 of a circle. See, most curvature, most curvaceous needle. So when our friend Karan said that we have to use circular needle, he probably meant that we have to go deep. But liver is a big structure. You don't need such kind of curved needles over there. The only thing is you should be concerned about the tip of the needle. You should be concerned about the tip of the needle. I'll just show you. See, these are all the taper point, the blunt taper point. So this is the taper point which we will use to uh, suture laceration of the liver. Now you see, this is the insignia, the logo for conventional cutting needle. The cutting edge is on inside. Now this is the logo for reverse cutting needle. The cutting edge is on outside. And this is the first needle, the needle A in the question. Fine. Taper cut, right? This is used for microsurgery, micropoint spatula. So all the type of needle. You see this image is showing the difference between how the conventional cutting needle can be dangerous and how the reverse cutting needle is safe. The reverse cutting needle is safe because this may not be visible on your screen. Let me zoom it up. See, the conventional cutting needle can cut the tissue. Fine. Reverse cutting needle may not cut the tissue because the cutting edge is on outside. The cutting edge is on outside. You just need to be sure about the logos, right? So I'm moving forward. So all the different types. See, Aberdeen knot. So Aberdeen knot is also called as cobbler's knot. Cobbler knot. Cobbler knot. Right? Aberdeen knot. So it is applied at the end of running sutures. The cobbler knot. Right? So what kind of suture is this? This is vertical mattress. Why? Because all the holes are in one straight line. All the holes are in one straight line. This is horizontal mattress. Horizontal mattress. one thing more I wanted to show you here. Yes. So what is D? D is the distance between tip and swag end of the needle. Swag end is where the suture is attached. So this distance is the chord. This distance is the chord. This E is the radius. Diameter is the the thickness of the needle. Diameter is the thickness of the needle. Thickness of the needle, that is the diameter. Fine. That is all about the needles. So basically it's all taken from here, so let's not discuss it further. Let's move to the question. Okay, the structure being sutured is, this is the question, the structure being sutured is, Dr. Ashwini. Yes, yes, what kind of anastomosis this is? You've already seen this. So this is Carroll anastomosis. Carroll anastomosis. So we are using it for blood vessel. Basically, in the blood vessel, we don't want to expose the tunica intima. We don't want to expose the tunica intima. So it should be watertight. It should be watertight. Fine. So you see here there are three, one, two, and three stray sutures. Fine. Right, so this was an easy one. So we move to the next question there. BP handle used in this blade is. So what is BP handle? It is basically barred Parker handle. Yes, someone please. Dr. Bharat, Dr. Karan, Dr. Priyadarshini, Mohib Khanji, Ashwini, Rushabh. Hmm? No. First of all, tell me what is the number of this blade? What is the number of this blade? And for what purpose it is used? For what purpose is this blade used? So first of all, this is 12 number blade. So this is used for suture removal, and this is also used in orthopedic practice. This may also be used as stab incision, may also be used for stab incision, though for stab we prefer blade number 11. Blade number 11. Fine. So all the small blades, they should be inserted in BP handle number 3. All the big blades, they should be inserted in BP handle number 4. I'll show you an image. See here. All these small blades, all these small blades. Fine. So which of these you should remember? Blade number 10, blade number 11, blade number 12, because they have peculiar, they have different shape. So these are the blades which you should remember. Blade number 14, blade number 21, blade number 22, and blade number 23. These are all the blades whose shape you should always remember. These are the blades whose shape you should always remember. Fine. So this is for making stab incision. Oh, I forgot this one. This is for making small incision. This blade, as you know, this is universal. Fine. And this blade is used for making abdominal incision. Abdominal incisions. Fine. And this, it is for use, it is for suture removal. For suture removal. Right. Right. So we move forward. The following instrument is avoided in. The following instrument is avoided in. First of all, what is this instrument? What is this instrument? First of all, so this instrument is the lead for monopolar cautery. This is the instrument, the use for monopolar cautery. Fine. So monopolar cautery travels through the entire tissue. Travels through the entire tissue. Fine. So in the penis, it may coagulate the delicate arterial network. Fine. While you are performing thyroidectomy, guys, can you just wait for a minute, please? I smell something bad. Is everything all right? I noticed some abnormal kind of smell. Maybe the door is open, maybe the window is open. Please check. Right. So we should not be using monopolar cautery both in circumcision as well as in thyroidectomy, because there the recurrent laryngeal nerve. See, the nerves, they have got very low resistance for current. So they will immediately pick up the current and they may be damaged in the process. So we should not be using in both. In both of them, if required, we can use bipolar cautery. So bipolar cautery will have two prongs. Bipolar cautery will have two prongs. Fine. So only the tissue between the prongs will carry the current. Will carry the current, and the current will flow like this. This will be the direction of flow of the current. Fine. The current will not, it will not disturb rest of the tissue. It will not disturb any other tissue. This will be the flow of current. So you can use bipolar cautery if you wish to. Again, this is these are the small questions and they are just based on identification, so they don't require much of hard work. Only thing is visual appeal. If you can check the visual appeal, so you have to identify the following instrument. Journey retractor. Why? Because it is solid on one side and because it is pronged on the other side. Because it is pronged on the other side. Let's not waste much of the time over there, and let's look at the other retractors. How do the other retractors look like? See, Jalopy retractors is used for thyroid and other head and neck surgeries. This is how the Jalopy retractor looks like. This is how the army, navy. Army on the surface, navy deep. So this part will go to the deeper structure. This part will stay at the surface. This part for use at the surface. Fine. This part for use at the surface. Right. Langenbeck retractor is also used for surface surgery. It is not used for going too deep. Not used for going too deep. Identify the following instrument. Again, I believe this won't spend, we're not spending much of the time over here. Identify the following instrument. See, just a minute. Don't ever rush to answer a question. You notice what is there. See, no serrations. It is absolutely smooth. That means it is an yes, of course, I'll provide this PPT definitely. I mean, this PPT is for your use only. Now you see there are no serrations at all. Can you notice any kind of serrations? No. There is a lock. Fine. This all you have to see while you are trying to identifying the instrument. So this basically is an atraumatic instrument. That means it will be using this on delicate structures. We will be using this on delicate structure, the structures which we want to preserve, the structures which we want to preserve. Fine. So Dr. Akash has finally given the right answer. It is a Setinsky clamp. Setinsky clamp, which is used for ligating the bleeding vessel, the bleeding vessels. Fine. Let's have a look at how the other instrument looked like. Most of you answered it as bulldog clamp. Let's see how does the bulldog clamp looks like. So bulldog clamp, you know, it is a cross action clamp. Cross action clamp. Fine, like this. Cross action clamp. You press upon here and the prongs will open. The prongs will open. This is also an atraumatic instrument. Cocker forceps we had seen yesterday. There will be, you know, the tooth at the end, serrations, and then there will be lock. Fine. Cryles, again you can see there are serration, there is lock because there are serrations. So this is a traumatic instrument. This is a traumatic instrument. Fine. For example, you know, the Alice forceps is traumatic instrument, whereas the Babcock forceps is atraumatic. Babcock forceps is atraumatic. Right? Now, injuries in which of the zone can be immediately life-threatening? Injuries. This is an easy question. This is an easy question. Nikhil, Akash, both are working at it. Mohib Khan. When all of you answer this, you know, I get scared that maybe I'm going to answer something wrong. But you see, the zone 1 will compromise the airway immediately. Zone 1 will compromise the airway immediately, whereas all what will happen in the zone 2 will be bleeding. And if you read correctly, fine, let's uh, let's sum it up. Let's very easily sum it up for you. Fine. So you see, zone 2 is from cricoid cartilage to the angle of mandible, because many of you answered zone 2. So let's very quickly. So you see, zone 2. So it will extend from cricoid cartilage to the angle of mandible. Fine. So here the only problem is bleeding. So bleeding will occur from branches of carotid artery. Fine. Now this can be easily managed. This can be easily managed. This can be easily managed. The real threat comes from zone 1. You see here, from this zone 1, the real threat, you see it extends from the sternal notch to the cricoid cartilage. The problem, trachea is extremely superficial, and you know, if the trachea is cut, your patient won't be able to breathe. Your patient won't be able to breathe here. Fine. So zone 1 is from suprasternal notch to the cricoid cartilage. Airway is superficial. Airway is superficial and can be compromised, and it can be compromised easily. Can be compromised easily. Fine. So the injuries are immediately life threatening. Injuries, they are immediately life threatening. Now you remember about the zone 3. So zone 3 extends from angle of mandible to the base of skull. Fine. So if the bleeding may occur from internal jugular vein. Fine. So this bleeding can be obscured. So we require Angiography. We require angiography to localize the source of bleeding. Yes, Dr. Rishabh, zone 2 is most commonly injured, but Dr. Lokesh is also right that there is maximum mortality in the zone 1. Maximum mortality in the zone 1. Right? So you should be always careful, because here, now you see here, you have also read it that, let's say, what is this? So this, as you know, is the anterior triangle. Fine. And this is the posterior triangle. So injuries in the posterior triangle are safe. Injuries in the anterior triangle, they are grossly unsafe. They are grossly unsafe. Fine. That is what you need to remember there. That posterior triangle is safe, anterior triangle is unsafe. We were talking about the neck injuries. We were talking about the neck injuries, right? So I'm moving to the next question. Okay, then that's another easy one. That's another easy one question. 42-year-old taxi driver is admitted to intensive care unit after a high-speed collision. MRI scan was done, which shows evidence of diffuse axonal injury. See, I hope you guys are aware, when you have read the topic of trauma, that diffuse axonal injury, I'll write it over there. Diffuse axonal injury cannot be seen on CT scan. It can be appreciated only on MRI. It can be appreciated only on MRI. So it occurs due to shear forces. Shear forces, that means one part sliding over the other. Gray matter sliding over the white matter. Fine. Now your patient practically has a head injury. Fine. So that means your patient is prone to develop Cushing ulcer. So let's see how. Attending clinician noticed coffee ground material coming from. That means some kind of digested blood is coming. Some kind of digested blood is coming. Fine. So remember what we read yesterday. In Cushing ulcer, what was happening? The acid production was increasing. The acid production was increasing. Fine. So we have to curb the acid production, and what is better than IV, intravenous PPI, proton pump inhibitor. Fine. Oral, we won't be able to use here. Fine. Though they are also better option, but here, because the patient is in not in the best of the state, so we'll be using something which is IV. Right? So IV PPI drip would be the right answer there. See, we are trying to prevent our patients from Cushing ulcer. Fine. That is the complication. Fine. So we don't want any further blood loss. So we'll be using IV proton pump inhibitor drip. Any one of you who wants to differ, maybe please, may also share your opinion over here. Right. So we move to the next question there. Yes. Please analyze this image for a while. Yes, patient is unconscious. You see, we can give orally through the Ryle's tube, but we want to prevent. We want to prevent any other extra complication. We want to prevent any other extra complication. So we'll rather be using the IV. Yes, please answer this question. No. First of all, what is this patient suffering from? What is this patient suffering from? You see here, there is hemisection. That means half of the cord is destroyed, other half is normal. Other half is normal. Fine. Now you see here, there is loss of pain, loss of temperature, and light touch on the opposite side. Dr. Kritarth gave the right answer. It is Brown-Sequard syndrome. So your patient is suffering from Brown-Sequard syndrome. There is loss of motor function, vibration, position on the same side. On the same side. So this is Brown-Sequard syndrome, which most commonly occurs from penetrating trauma. Yes, ipsilateral paralysis. Why? Because the same half of the spinal cord is affected. I'm going to share the another screen because many of you did not want to answer this question. Fine. So I'm going to share another image also. So we'll spend just 20-30 seconds on this question. You see here, this is Brown-Sequard syndrome. We move to the next question there. Next slide there. I want you to have a look at this image. Have a look at this image. See, this image has got all the things which we want. See, Brown-Sequard. Common mechanism is by penetrating trauma. Fine. When your patient has central cord syndrome, fine, there will be sensory and motor deficit. And in the question, it will be clearly written that it is more common on the upper limb rather than lower limb. Fine. Anterior cord syndrome. Fine. This occurs by flexion or vascular insult, hyperflexion or vascular insult, right? So there will be, you see, complete loss, but the only thing is it will retain proprioception and vibratory sensation as they are carried by the posterior part. Fine. So this, if you don't want to remember the other cord syndrome, do remember the Brown-Sequard syndrome. This is important to remember the Brown-Sequard syndrome. This is important. You see here, trauma, gunshot. This is also a type of penetrating injury. Fine. Stabbing, that is also a type of penetrating injury, right? So this is common. Too much of trauma. Please answer this question. Please answer this question. So we are talking about a retroperitoneal injury. That was an easy one, right? That was an easy one. So because it has got all the vascular structure, fine? It has got all the vascular structures. And I hope you guys are aware about this mnemonic. SAD puker. Fine. SAD puker. The suprarenal glands. This is for aorta. This is for duodenum. Fine. Again, this is the pancreas, ureter, fine, colon, and then these actually are the kidneys. Fine. Fine. Esophagus, this I believe seems to be an aberration, even this, because they are not retroperitoneal, rather we can call them extraperitoneal. They are not inside the peritoneum. SAD puker. This is the mnemonic for the retroperitoneal organ. Coming back to the question, you see the zone 1 is in the midline, is in the midline. Fine. Now, you don't need to remember this. Fine. Only thing is because it has vascular injuries, so all the injuries will require surgical exploration. Zone 2 is on lateral side, is on lateral side. Fine. So, don't need to remember this. Only thing is you have to explore the penetrating trauma, and zone 3, pelvic and retroperitoneum. Fine. So you just have to explore if there is any expanding hematoma. Again, you may skip remembering the anatomical details there. Right. With this, we move to the next question. And make no mistake, while you read the statement, there is a catch in the statement. There is a catch in the statement. There is a catch in the statement. Please read this question and look at the image. Have a look at the image. What is special about the image? What is special about the image? Look here. Look here. So this is called as flesh eating disease. What is being shown by these arrows? That the muscles, they are spared. Muscles, they are spared. Muscles, they are not involved. Now tell me, what is the diagnosis? Muscles are spared. What is the diagnosis? Now, what is the catch? The catch is that your patient is healthy. Your patient is non-diabetic. Your patient is non-diabetic. First of all, this disease which the patient is suffering from is necrotizing fasciitis. Necrotizing fasciitis, and it is most commonly caused by beta hemolytic streptococci. It is most commonly caused by beta hemolytic streptococci. Fine. Now you see here, see the sheet. Necrotizing fasciitis, necrotizing fasciitis, type 1, type 1. This is most common, and most of the time it is polymicrobial. Fine. That means many of the bacteria are involved. Here also you see streptococci is present. Streptococci is present. Clostridia will be there. Anaerobic infection will be there. Fine. Enterobacteriaceae. This you may not remember. Fine. Now this is the most common type. This will be seen in diabetics. This will be seen in immunocompromised patient. Fine. But when we talk about type 2, this is the one which is seen in healthy individuals. Maybe you don't want to go in too deep. Fine. But these are the few things which you should remember about the necrotizing fasciitis. Necrotizing fasciitis. Fine. So it is called Fournier gangrene when it involves the small area like scrotum. When it involves the small area like scrotum, it is called as Fournier gangrene. So most commonly it is polymicrobial. Most common single organism is streptococci. Characteristic clinical feature is muscle sparing. Muscles are not damaged. Muscles are not damaged. Fine. Remember, remember the muscles, they are damaged. Muscles, they are damaged in gas gangrene. So in the gas gangrene, myonecrosis is characteristic, but here the muscles, they are totally spared. Muscles, they are totally spared. That is a characteristic clinical feature. That is the characteristic clinical feature of this condition. Characteristic clinical feature of this condition, right? So with this, we move to the next question, and if you guys have any query, you can always ask me. Answer this question, please. The following condition is common in. Yes. So your patient is suffering from keloid. Your patient is suffering from keloid, which is common in black races and young individual. 10 to 30 years is the most common age. 10 to 30 years is the most common age. Fine. So when we talk about keloid, the first treatment usually is triamcinolone. Fine. Then you can use laser debulking with either radiotherapy or silicone sheets. With radiotherapy or silicone sheets. Just remember, just a minute. Other day in my hospital WhatsApp group, we were discussing something about the keloid. Let me just tell you what was the doubt all about. Yes. So, so in the keloid, some of the students, they asked me about a common doubt. They asked me about a common doubt whether the keloid has what type of prominent collagen is there in the keloid. Fine. So keloid has type 3 collagen in the proliferative phase. Type 3 collagen in the proliferative phase, and it has type 1 collagen in the maturation phase. When you must have read, this doubt must have come to your mind also, that what kind of collagen is predominantly seen in the keloid, right? So if you have to answer one answer, you go in for type 3 collagen. You go in for type 3 collagen. This doubt usually comes to the mind because two of the standard textbooks, they have different answers. So if you have to give one answer, you can easily go in for type 3 collagen. You can easily go in for type 3 collagen. So it is common in the black races, young population, right? And it is the common site are the sternum, as you guys have answered in the uh, the the chat box. They are open in the telegram. Fine. So this is collagen. So it continues to grow beyond 1 year. In contrast, if we talk about the hypertrophic scar, this is slightly more common in children, and it is common on the flexor surface. There, the drug of choice is triamcinolone, and that is the only treatment generally which is required. We now move to the next question. Do let me know if I have to adjust the speed. Hmm. Yes, read this question. I'll read along, or I'll give you some time to read this. I'll just underline the catchwords. Dr. Mohit Khan, Dr. Akash, your answer is correct. But just tell me, how could you reach this answer? Answer is C. But just tell me, how could you read this answer? How could you reach this answer? The reason. Yes, Dr. Akash, decrease urine output. What does that indicate? Decrease urine output. What does that indicate? Now you see here. In this question, your patient basically is suffering from abdominal compartment syndrome. Your patient is suffering from abdominal compartment syndrome. So there is increased pressure in the abdomen. Why increased pressure? Because the fluid has leaked out of the blood vessels and collected in the retroperitoneum. Second, he has been given aggressive, that means too much, aggressive fluid replacement. Fine. Now both of them, they have caused organ failure. They have caused organ failure. And whenever there is organ failure in abdominal compartment syndrome, that calls for laparotomy to reduce the pressure. That calls for laparotomy to reduce the pressure. To reduce the pressure. That calls for laparotomy. Right? Now, again, this is a separate catchword. This is a separate catchword. Can you see all the options clearly? If you cannot see, do let me know. Just read the question. This much time you will get in the exam. So first you have to tell me what is the diagnosis. What is the diagnosis? The answer will come from here. The answer will come from here. Dr. Mohit Khan, you are close. You are close. Now you see here. What does the language of the question read? The language of the question reads that your patient is obese. Now let's say this is the OT table. Fine. Now here This is your patient. So these are the hips of the patient, and let's say hips of the patient. Let's say this is the back of the patient, and here is your patient. Here is your patient, right? The smiling patient. I got a very bad hand at drawing. Fine. You see, your patient is being operated. Now, because he is too obese, so the gravity is acting in this direction. Just notice the condition of these parts of his body. Notice the condition of these parts of his body. Fine. The patient has been lying on the table for long period of time. That means there has been maximum pressure. There has been maximum pressure on these parts. Fine. So these parts, let's call them parts number 1 and part number 2. These parts, they have been compressed for long period of time. So that means these parts, they developed compartment syndrome because the patient has too much weight. We believe that the blood vessels in these parts, part 1 and part 2, they must have been compressed. They must have been compressed because of excess weight of the patient. Now, this must have caused muscle damage. Now, when the muscle is damaged, what happens? Myoglobin leaks out. Myoglobin leaks out. You see here. That is why I told you the answer will come from here. Myoglobin leaks out, which changes the color of the urine to dark brown. Which changes the color of the urine to dark brown. That means your patient is having myoglobinuria. Myoglobinuria. Fine. So what is the optimum management of myoglobinuria? You have to perform forced alkaline diuresis. You have to perform forced alkaline diuresis. Fine. How can you perform forced alkaline diuresis? See, if you give 1 liter of IV fluid, it will cause diuresis. Fine. But we need, yes, myoglobin is causing renal failure. It will cause diuresis, but we need something which can push. Now, from your knowledge of physiology that myoglobin, first of all, it is a large protein. Second, that it is a negatively charged protein. Fine. So let's say these are the renal pores. Fine. Myoglobin will be stuck over here. Myoglobin which will be stuck over here, and it has got a negatively charged. If we add bicarbonate, fine, if we add bicarbonate, bicarbonate is negatively charged, myoglobin is negatively charged, so they both will repel each other. Ultimately, what will happen, that myoglobin will be thrown out of the system. Myoglobin will be thrown out of the system. Fine. And you see, once the myoglobin is thrown out, once the myoglobin is thrown out, the renal pore will open again. The renal pore will open again, and the patient will be able to regain the urine output. Patient will be able to regain the urine output. So this is incorrect. Fine. Injection furosemide again will cause diuresis. But what about the myoglobin which is stuck there? Fine. So I believe this is a better option because this will cause forced, fine, alkaline. Sodium bicarbonate will cause alkaline diuresis. Earlier, this question they used to ask is in the form of one-liner format. What is the treatment of myoglobinuria? The treatment would be forced alkaline diuresis. Just a second. So the treatment would be forced alkaline diuresis. Fine. Now, when we are here, let's discuss what actually happens if your patient suffers from crush syndrome. If your patient suffers from crush syndrome, see, potassium, potassium is intracellular. When the muscles are crushed, potassium will be released. So your patient will have hyperkalemia. When the muscles are crushed, fine, what will happen? The myoglobin will be released, and is a negatively charged protein, so it will bind with calcium because calcium is positively charged. So your patient will have hypocalcemia. Here also the treatment is forced alkaline diuresis. Fine. So C would be the right answer there. Which of the following device is helpful in transfusing? Yes, Dr. Anmol is trying this time. Yes, so what is this device? First of all, what is this device? This device is a Y connector. Fine. So from here, you can insert blood. That means packed cells. Packed cells because they are very dense. From here, you can insert saline to improve the flow. Fine. To improve the flow. To improve the flow. Fine. Now, please tell me which of the IV fluids can be transfused along with blood. Ringer lactate 0.5% saline, 5% dextrose, 10% dextrose, or none. Which of the following IV fluids can be given along with blood in the same set? Let's call this A, B, C, D, and E. This is the right answer. Only and only normal saline can be given. Only and only normal saline can be given. No other fluid can be given along with the blood. No other fluid can be given along with the blood. Fine. Okay. One more question coming up. There is a concept of leukocyte poor blood. Leukocyte poor blood. This will reduce the incidence of This will reduce the incidence of which infection? This will reduce the incidence of which infection? Which viral infection incidence will be reduced? This reduces the incidence of cytomegalovirus. Cytomegalovirus. Fine. No, no, no. Don't think like that. Yeah, I mean, it was just this reduces the incidence of cytomegalovirus. Okay, we move to the next question there. Bombay blood group. Which of the following antigen may be present? Which of the following antigen may be present in the Bombay blood group? Forever single. Dr. Rahul. Don't match both of them. Forever single, Dr. Rahul. So, when we talk about the forever single, if you happen to be a boy, what will you be called in Hindi? You'll be called Sakat Londa. So the answer is 4, none of the above. None of the above. Fine. See, this is how the H antigen form. Fine. H antigen is the base. H antigen is the base on which A and B antigen they are built. On which A and B antigen they are built. Fine. Now, you see here. This is how the A antigen is formed. This is how the A antigen is formed. Fine. And this is how the B antigen is formed. This is how the B antigen is formed. When this is added, the B antigen is formed. Fine. Bombay blood group. This is special about Bombay blood group. They don't have H, A or B antigen. They don't have H, A or B antigen. Fine. Now, because they don't have these antigen, so they have strong anti-A, anti-B and even anti-H antibodies. Even anti-H antibodies. Fine. That is the problem. So, what do the Bombay blood group people do? What do the Bombay blood group people do? Fine. They store their own blood. They store their own blood. Fine. So when they store their own blood, what do they have to do? They have to get it lyophilized. They have to get it lyophilized. Fine. Now this lyophilized RBCs, they can be stored for around 10 years. They can be stored for around 10 years. Fine. They can be stored for around 10 years. Okay. Now, why is fresh frozen plasma called fresh plasma? I'll ask you easy questions only, don't worry. Why is fresh frozen plasma called fresh plasma? Because it is frozen immediately. It is frozen immediately after donation. What do you mean by immediately? That means it is frozen within 8 hours. It is frozen within 8 hours. If you cannot freeze it, it becomes PF24. That means plasma frozen within 24 hours. Plasma frozen within 24 hours. Now, there is a product called PNF. That means plasma which is never frozen. Plasma which is never frozen. Fine. Now the Schwartz, the standard textbook of surgery, it says that this has got better hemostatic properties. It has got better hemostatic properties, then the then the frozen plasma, fine, then the frozen plasma, okay, then the frozen plasma, okay. Now, so it has to be thawed at 30 to 37 degrees centigrade water bath if we want to use it. My question is that which two clotting factors are we worried about? Which two? I have four screens open in front of me and I don't know how on which screen I should speak to you. So I'll speak on any of the screen. So which clotting factors are we worrying about? Are we worried about when we take care of the storage of plasma? See, we store it at minus 42 degrees centigrade. Yes. So now we can use it for 2 years. Now we can use it for 2 years. Fine. Okay. If I say that I want to prevent, last question here. If I want to prevent graft versus host disease, which product shall I use? Which product shall I use? If I want to prevent graft versus host disease, which product shall I use? Which product shall I use? No, Dr. Sachin, every time it's not going to be the same. Every time it's not going to be the same. So, the answer would be B, irradiated RBCs. Fine, because this irradiation will kill all the white blood cells, and white blood cells, they are the causative factor for graft versus host disease. They are the causative factors for graft versus host disease. Fine, this is what we want to prevent. This is what we want to prevent, right? Okay, just so if your patient develops septicemia, most commonly it is going to be gram negative organisms. I wanted to ask you as a question, but then I said it's getting too much for you. So let's not waste some time. Fine. So Bombay antigen people, they have to get their RBCs lyophilized. They have to get their RBCs lyophilized. Then they can store it for 10 years. Lyophilized means they will be converted to powder. They will be converted to powder. Okay, answer this question. Mohib Khan, Dr. Mohib, am I pronouncing your name correctly? Dr. Mohib, right. So you have to answer this question. Great, thank you. So you answer this question now. Anyone from any part of Punjab over here, or anyone who can understand Punjabi? It's about the Mohib Khan, and Jada Pole, Ohoi Kunda Khole. So he is the one who replied, and he is the one who's going to answer this question. Please have a look at this question. That's an easy one. That's an easy one over there. Wow, that's great. है ना, पंजाबी और आलू जगह जगह मिल जाते हैं. हमें तो भैया खाने में भी रोज आलू ही मिलते हैं. No, 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 no. Why are you guys giving the wrong answer there? That's such an easy question. Why are you giving such a wrong answer there? That's an such an easy question. You should not give wrong answers here. Yes, so finally Dr. Nikhil gave the right answer. See, the catchword is the age, 72-year-old women. 72-year-old women. Fine. Now you see, very quickly, let's discuss. See, the table which I wanted to discuss yesterday. Yesterday, many of you felt that we are going too deep. Fine. But even if we are going too deep, please allow me only 3-4 minutes. Please allow me only 3-4 minutes. I'll discuss a table and everything regarding the thyroid cancer will become amply clear. Will become amply clear. Fine. So please allow me to discuss this table. Fine. Here we will write papillary carcinoma. Here we will write follicular. Here we will write Hurthal cell. Fine. Here we will write Hurthal cell. Fine. Here we will write medullary. Here we will write anaplastic. Fine. This is important. It won't take you'll see it won't take more than 2-3 minutes. Fine. Now, incidence most common 70 to 80%. Follicular and Hurthal cell both around 10%. Medullary less than 5%. Anaplastic 1 to 3%. When we talk about the age, fine, papillary 30 to 40 years. Follicular is around 50 years. Follicular is around 50 years. Medullary 55 to 65, and then it may occur in adolescent also. May occur in adolescent also. Anaplastic 70 to 80 years. 70 to 80 years. And it goes without saying, all of them are common in females. All of them are common in females. Fine. Primary mode of spread. So this goes by lymph node. All of the questions, 100% all of the question about cancer will be from this table only. Follicular, blood. Hurthal cell, blood plus lymph node. Medullary, blood plus lymph node. Fine. Anaplastic. Anaplastic will go by direct mode. So the common associated gene mutation, B type RAF, here P10, PAX8, P10, PAX8 gene mutation, they are commonly associated. Medullary, RET gene mutation, here also B type RAF gene mutation, they are commonly associated. Distant organ affected, lungs. Follicular and Hurthal cell both, bone. Medullary, liver. Here also lungs. Fine. Prognosis, excellent. Fine. Here the prognosis is poor. Here the prognosis is very poor. Here the prognosis is very poor. Here the prognosis is worst. Fine. That is basically that is all what you need to remember about this. All what you need to remember about the cancers. Fine. That was an easy table. Now let's see what is there in the question. First of all, the age. Fine. Age. You can see by yourself. Anaplastic age is 70 to 80 years. For this it is 50. For this it is 20 to 40. For this it is 30 to 40. Fine. And all of them, they are common in females. Rapidly growing lump. So rapid, see, follicular is aggressive. But when we talk about anaplastic carcinoma, this cancer is extremely aggressive. Fine. So this is slow growing tumor. The lump has been causing difficulty in swallowing for the past few days. That means it is compressing upon the trachea. It is growing so rapidly that it is compressing upon the trachea, that is fixed to the overlying skin. You see, the cancer, anaplastic cancer, will spread by direct contact. So, in all probabilities, this is going to be the anaplastic carcinoma. Just listen for 20-30 seconds. See, your examination and the NEET PG both are at the same page now. But still, in our examination, the only benefit which we have is that our questions, they definitely will have a keyword. Even if it is a clinical scenario based question, they will definitely have a keyword, and you have to look for that keyword, that hint word. So you will be able to easily answer this question. For example, here the age was an easy hint. The age was an easy hint, right? We move to the next question. Now you see, again there are, I can directly spot that there is a keyword, that there is a keyword. Read the statement, then I'll underline the hint word. So let me underline the keyword for you. Now, could you answer it correctly? It is not Hashimoto. Look at the age. This is the right answer. This is the right answer. 30 to 50 years of age. Fine. Hashimoto basically is common in 50 to 70. Now you see here. Why did I give you the right answer here? Temperature. Decurvane thyroiditis is also called as viral thyroiditis. Is also called as viral thyroiditis. It is also called as subacute thyroiditis, and this has a painful goiter. This has a painful goiter. Viral thyroiditis has a painful goiter. Fine? Painful goiter, right? Yes, granulomatous thyroiditis. The painful goiter is present. Painful goiter is present. So if we talk about the thyroid status, it would be like this. Euthyroid. Suddenly, the patient will become hyperthyroid. Then the patient will become hypo, and after a while the patient will again become euthyroid. Patient will again become euthyroid because it is viral thyroiditis. There will be pain, there will be fever. So your patient automatically has got viral thyroiditis. Fine. Yes, yes, yes. It's self-limiting. Because we discussed too much of thyroid yesterday, so let's not spend too much time over this. Please answer this question. Please answer this question. So let's not waste too much time, because yesterday also we spent so much time over this question, but then I was told to keep some question from the yesterday's topic also. So Lindsay tumor basically is encapsulated variant of papillary carcinoma. It is encapsulated variant of papillary carcinoma, Lindsay tumor. Fine. Yes, again, we're discussing the topic of neck. So this question is not from thyroid but from neck. Yes, 11-year-old girl is brought to surgery OPD after her mother noticed painless swelling on the left side. She has a recent history of acute respiratory tract infection. On examination, a smooth, fluctuant non. This is the catchword. This is the catchword. So, if there is swelling which has occurred after, history of acute respiratory tract infection, it is going to be a bronchial cyst. It is going to be a bronchial cyst. Why it is not a thyroglossal cyst? Because this is a midline swelling slightly to the left. Cystic hygroma. It is found in the posterior triangle. Remember, cystic hygroma will always be found posterior to the, I mean, not always, but most commonly it will be found posterior to the sternocleidomastoid muscle. Sternocleidomastoid muscle tumor will be present in the body of the sternocleidomastoid muscle and not anterior to it. So the only swelling which is present anterior to the sternocleidomastoid is the bronchial cyst. It is the bronchial cyst, right? So thyroglossal, not, and this is the right answer. This is the right answer. It's not the time for lunch break, Dr. Priyadarshini. नहीं बेटा नहीं. We started at 11 o'clock and it's just 1 hour 40 minutes. Let's start read for 15-20 minutes more. Then we'll take a break of around 10-15 minutes. We'll take 2 breaks today. Nikhil, is you? Oh, Nikhil, what makes you hungry? Lucky guys. Yes, that's an easy one. Let's not discuss food over here. No, it's wrong to discuss food in front of a Punjabi. So I don't know this guy, but Dr. Rishabh is definitely a Punjabi. Okay, so read the question first. Okay, read the question, please. अभी मैं कुछ बोलना नहीं चाहता गुजराती के बारे में. Yes. So first of all, what is this patient suffering from? What is this patient suffering from? Emergency. See, first of all, again the age. Again the age. Fine. Again the age of the patient is an important. गुजराती है ना, तभी तो दूसरे की चॉकलेट से सार दिया, खुद अपनी चॉकलेट नहीं खिलाई. Bajwa sahab, at least you are Punjabi. Okay. Incessant crying. These are the catchwords. Patient got further worried when the child passed blood mixed mucus. Blood mixed mucus in the stools. Great, good to see you. On further detailed history, the patient parents revealed episode of crying to be present along with the drawing of his legs up to the abdomen. See, there are so many catchwords in the question. Fine. Now, whenever you get to see these lines, drawing his legs up to the abdomen, the only diagnosis that should come to your mind is interception. Fine. First of all, the age. What happens here? The hypertrophied Pierce patches, the hypertrophied Pierre patches, they act as a lead point. They act as a lead point. Fine. When we talk about the blood mixed mucus, what is that? That is the red currant jelly. Red currant jelly. Fine. Red currant jelly. Fine. So in this case, this is the adequate treatment. The barium enema happens to be the adequate treatment. We don't need to give any further treatment. We don't need to give any further treatment. Yes. Why we did not choose laparotomy? Why we did not choose laparotomy? Can any one of you please tell me why we did not choose laparotomy as the answer? Why we did not choose laparotomy as the answer? I will erase everything and then you have to tell me why this option is incorrect. You have to perform surgery even on a single day, baby. No, no, no. Again, the question is there. No, 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 no. Here the answer is there. Why? Look here. It is the first instance. It is the first instance. So if there is third recurrence, then you have to perform surgery. It is the third recurrence. At that time, you have to perform surgery. At that time, you have to perform surgery. Fine, because it has happened for the first time. All you just need is barium enema. All you just need is barium enema. That will correct. Fine. What is the what is the better option than barium enema? You can try air enema. You can try air enema. Fine, you can try air enema because this is just a first instance. So we will avoid doing any kind of surgical intervention, and air definitely is better. Air definitely is better than barium, right? Okay, just have a look at this question. Just have a look at this question. We are starting with the topic of GIT now. We're starting with the topic of GIT now. So what I want to know is, I want you to focus on this arrow. I want you to focus on this arrow. The question will be there on the next slide. Once we have a look at the question, once we have a look at the question, I'll again bring you back to this slide. The pathology arising from area marked with an arrow in the below presented picture is. Don't answer, don't answer as of now. Have a look at the image again. Have a look at the image again. Have a look at the image again. So there's a disclaimer. This is not a Zenker's diverticulum. This is not a Zenker's diverticulum. This is not a Zenker's diverticulum. This is not Killian dehiscence. I am talking about this area. I am talking about this area. The area which is below the cricopharyngeus. The area which is below the cricopharyngeus. Yes. So, this is limar diverticulum. This is limar diverticulum. See here. See here. So, Killian dehiscence, this picture is not clear. So, Killian dehiscence is between cricopharyngeus and thyropharyngeus. Is between cricopharyngeus and thyropharyngeus. So, this area which I have shaded blue right now, this area is Killian dehiscence. This area is Killian dehiscence. Fine. This area which is below the cricopharyngeus, the area which is below the cricopharyngeus. You need to have this idea, bro, because you know they are sick of asking the old questions. Fine. So this area is limar triangle. This area is limar triangle. When the diverticulum arises from the cricopharyngeus muscle, fine. This is called as Killian Jamison diverticulum. Killian Jamison diverticulum. Fine. So from this area, let me write. From this area will arise Zenker. From this area will arise Killian Jamison. From this area will arise Limar diverticulum. Limar diverticulum. Fine. Now, when we discuss the Zenker's diverticulum, when we discuss the Zenker diverticulum, you need to be aware about some of the important points. First of all, you know it is a pulsion diverticulum. It is not a true diverticulum. Fine. It is common in elderly. So most common age is around 60 plus. Is around 60 plus. And you know it is the most common diverticulum of esophagus. It is the most common diverticulum of esophagus. Earliest and most common symptom. Earliest and most common symptom would be dysphagia. You know, because why dysphagia? You know what is the problem in the Zenker's diverticulum? Why did the Zenker diverticulum start to appear in the first phase? It started to appear because there was lack of coordination between thyropharyngeus and cricopharyngeus. That means they are moving on their own. Whenever they feel like moving, they are moving. Fine. So your patient will have uncoordinated muscle activity. So that is why your patient will have dysphagia. Your patient will have dysphagia. You know, all these features, halitosis, regurgitation, they occur at a later date. They occur at a later date. Fine. So for diagnosis, we prefer barium swallow. It goes without saying that endoscopy is avoided because this is dangerous. Endoscopy is avoided because this is dangerous. You know, it can cause perforation. It can cause perforation. Now you will answer me. You will answer me with the name. If your patient is elderly plus your patient is unfit, what is the preferred treatment? What is the preferred treatment? If your patient is elderly and your patient is unfit, how will you treat this patient? How will you treat this patient? Yes. So if the patient is elderly and unfit, we will do endoscopic surgery. That means we will do Dolman operation. We will do Dolman operation. No, 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 no. No surgery is not the right thing to do, Dr. Harshita. Okay, if we go by the word of Dr. Harshita, she says no treatment. Fine. What is the likely complication? What is the likely complication which your patient can develop? What is the likely complication which your patient can develop? So if we don't perform any surgery, your patient can have aspiration pneumonitis, which can develop into lung abscess later on. Fine. Or your patient can develop squamous cell carcinoma. Your patient can develop squamous cell carcinoma later on. Squamous cell carcinoma later on. Fine. That is the problem which your patient may face. That is a problem which your patient may face. Fine. Okay. So optimum management of the following condition which is noticed on esophagoscopy. Question and answer both are there on the same slide. Please try to answer this question. Hmm. Nikhil. Dr. Akash gave the right answer there. Dr. Akash gave the right answer there. So your patient is actually having Schatzky ring. Schatzky ring. Fine. Schatzky ring. So your patient is having Schatzky ring. Now Schatzky ring, they are actually type B ring. Type B ring. Fine. Schatzky ring, they are type B ring. Type B ring. That means complete circumferential and submucosal ring at lower end of esophagus, at lower end of esophagus. So type A is a muscular ring. Type C is because of diaphragmatic impression, is because of diaphragmatic impression. Fine. Now if we give any kind of radial incision, fine, if we do circumferential excision, that will cause severe fibrosis, and we don't want any kind of fibrosis. We don't want any kind of fibrosis. Esophagectomy would be an over treatment. It would be an over treatment. Fine. It would be an over treatment. So the best thing is to do esophageal dilatation. Best thing to do is an esophageal dilatation. Investigation of the choice to diagnose this condition. So this happens to be barium swallow. Investigation of choice to diagnose the condition happens to be barium swallow. Fine. Barium swallow. Okay. So most of the time your patient only has obstructive symptoms. Some of the times the examiner may expand this question. So if there are obstructive symptoms only, all you need to do is dilatation. If patient has obstructive obstructive symptoms plus reflux. Obstructive symptoms plus reflux. Fine. Then what you need to do is dilatation plus anti-reflux procedure. Anti-reflux procedure like fundoplication. Like fundoplication. Fine. Now, you people know about the different type of fundoplication, right? The Dor fundoplication, Nissen fundoplication, Watson fundoplication. Fine. You know about them all. Dor, Watson, Topte, Belsey-Mark fundoplication, the Nissen fundoplication. You have read this. Fine. So you see Nissen is 360-degree fundoplication. Nissen is 360-degree fundoplication. Belsey-Mark is 270-degree. Yes. So Watson and Dor. So Dor is, you see, 180-degree. Watson is around 90-degree. Topte is around 270-degree. My question is slightly different. I understand that is a difficult question, but if you can answer this question, you are through. 100% through. I mean, nevertheless, even then also you are through. My question is, your patient has to undergo fundoplication, but there has been history of multiple surgeries in the upper abdomen. Upper abdomen. Which procedure is best suited for your patient? Which procedure is best suited for your patient? If there is history of multiple surgeries in the upper abdomen, which procedure is best suited? See, the idea which I am trying to convey you here is, if there is history of multiple surgeries in the abdomen, that means there will be too much fibrosis there. So if you again go to that area, you will be stuck up in the fibrosis. So you need to have a different approach. Belsey-Mark, it approaches the stomach through the thorax. Fine. So if there is history of multiple abdominal surgeries, we prefer the Belsey-Mark operation. I understand that was a very, very, very difficult question. Fine. Belsey-Mark. The idea I'm trying to convey you is that you can raise up your bar. Not a very difficult thing to do. This is the last question which we're going to discuss, and after that we'll take a break. Fine. And it's not going to be a lunch break, because I cannot continue for 3 hours straight with you. I cannot torture you guys. So we'll take 2 small breaks of 10-15 minutes each. Right? So please answer this question first. Yeah, sure. Yes, please answer this question. 62-year-old man suffering from eclasia cardia was being managed on medication. He later chose to undergo pneumatic dilatation for long-lasting relief. As per operative surgeon, the procedure went uneventful. That means he could not understand it. ध्यान कहीं और होगा उस समय. 6 hours later, the patient developed acute chest pain, fever, and tachycardia. That means your patient has probably developed the perforation of esophagus. You cannot use barium. You should prefer the water soluble gastrographin. If you do endoscopy, you may not be able to see the rent. You may not be able to see the rent. So the best thing is a water soluble contrast. Best thing is a water soluble contrast. Fine. Now, so ecclesia, the important questions there. Important questions in the ecclesia. What is the triad of ecclesia? Triad of ecclesia is weight loss, regurgitation, and dysphagia. Weight loss, regurgitation, and dysphagia. Fine. Now the next thing there, that it is common in the middle age group. Common in the middle age group. Now the male female incidence is almost equal. Male female incidence is almost equal. Now, as you know, it is the most common primary esophageal hypomotility disorder. Primary hypomotility disorder. I want you to be familiar with these terms. What is pseudoeclasia? Pseudoeclasia occurs due to tumor at the lower end of esophagus. Tumor at the lower end of esophagus. Tumor at the lower end of esophagus. Fine. Second is vigorous eclasia. What is vigorous eclasia? Vigorous eclasia is eclasia with diffuse esophageal spasm. Right? With diffuse esophageal spasm. Now, if you get the barium done, it will show rat tail appearance, also called as bird beak appearance, also called as bird beak appearance, also called as pencil tip appearance, pencil tip appearance. Fine, pencil tip appearance. Gold standard treatment is laparoscopic modified Heller's myotomy. Laparoscopic modified Heller's myotomy. Fine. So pneumatic dilatation is the only treatment which can give long lasting relief. It is better called as only non-operative treatment which can give long lasting results. Fine. Now you can also use botulinum toxin. Now there are two adverse effects of using botulinum toxin. One you will tell, other I will tell. There are botulinum toxin is not preferred. Why? Yes, botulinum toxin requires repeated application, short lasting result. Fine. Now the second thing, it makes the subsequent surgeries ineffective. It makes the subsequent surgeries ineffective because it causes fibrosis. See, you are giving multiple injections at one site. So this will definitely cause fibrosis. This will definitely cause fibrosis. So every problem, every treatment has got a problem. Pneumatic dilatation can cause perforation, and that is what we saw in this question. That is what we saw in this question. So there is a new treatment coming up. So that is POEM. Fine, POEM is per oral endoscopic myotomy. Per oral endoscopic myotomy. Fine. So what are the long-term complication? Again, the long-term complication is squamous cell carcinoma, or it can also cause mega esophagus. Mega esophagus. Fine, mega esophagus, which is also called as sigmoid esophagus. It's not a type of nodes. Basically, it is a type of endoscopic surgery. It is a type of endoscopic surgery. So in the nodes natural orifice, what have to you have to make an incision through and through. Here you are not making an incision through and through. You're not cutting it totally. If you cut it totally, then it would be called as nodes. Right? So with this, we take a break and we'll assemble again at let's say 125. Okay. So have a look at this image, and then I'm going to ask you a question on this image. Question based on this image. Yes. No, 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 no. Have a look. So this is a treatment based at management of gastroschisis. 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 The question is this, the one which is on your screens right now. See here, what is the difference between gastroschisis and omphalocele? There are two similar diagnoses, gastroschisis and omphalocele. Just a second. Now you see what is the difference between the gastroschisis and omphalocele. See here. You can see on your screen what is the difference between gastroschisis and omphalocele. So in omphalocele you can see that the protruding intestine, the intestine which is coming out of the abdomen, it is covered by a peritoneal layer. It is covered by a layer of peritoneum. That means it will not dry up. It will not dry up. While you can see that in case of gastroschisis, there is no covering. There is no covering of intestine. There is no covering of peritoneum. So that means here the intestine which has come out of the abdomen will get dried up immediately. It will immediately get dried up, and we don't want this kind of complication. We don't want this kind of complication. I mean, we don't want it to get dried up so easily. Fine. Now, you notice this. There is another image. See this image. Now this can give you very clear idea. You can easily remember this as a mnemonic. I'm sure many of you must have seen this mnemonic. Many of you must have seen this mnemonic. See, in omphalocele, it is all, omphalocele starts with the word O. So it is closed from all sides. Intestine is trapped inside a peritoneal layer. But in gastroschisis, you can see the intestine. It starts with the word G. So that means it can go out. That means it is exposed. That means it is exposed. It can get dried up very, very easily. There are chances of desiccation. There are chances of desiccation, and we cannot afford any kind of desiccation over here. We cannot afford any kind of desiccation over here. Fine. So we want to prevent this complication definitely. But what about the abdominal compartment syndrome? What about the abdominal compartment syndrome? Just have a look here. See here. So let's say this is your patient. Fine. Now this is abdomen, and through the abdomen, the intestine has herniated out. Intestine has herniated out. Now just imagine that if you do spot reduction, that means you do reduce the hernia immediately. Fine. You reduce the hernia immediately. That means you send all of the intestine back inside. Fine. And after that, you immediately apply the sutures. So what is there? Large mass of intestine, and you send it back inside the abdomen. That means there will be too much pressure. There will be too much pressure inside the abdomen. There will be too much pressure inside the abdomen, and that definitely will cause abdominal compartment syndrome. That definitely will cause abdominal compartment syndrome, and this is the last thing which we want. This is the last thing which we want to happen. Fine. Now what? See, we are stuck. First, if we don't send the intestine inside, it will desiccate. It will dry up immediately. If we send the intestine inside immediately, it will cause abdominal compartment syndrome. It will cause abdominal compartment syndrome. That is why we use this method, silo method. Fine. So what do we do in the silo method? We keep the intestine out of the abdomen only. We keep the intestine out of the abdomen. Why? Because you can see that the abdominal wall is hypoplastic abdominal wall. That means it is very small. So we just keep the intestine out of the abdomen, and meanwhile we allow the abdominal wall to grow. We allow the abdominal wall to grow. We allow the child to grow. When the abdominal wall becomes big enough, then we will send the intestine out, intestine inside. Fine. What do we do over here? See, today we apply the clip over here. After a few weeks, we will push the intestine inside slightly, and then we'll apply the clip here. We apply the clip here. That means we will push the intestine inside very, very slowly. By the time the intestine remains outside the body, we will cover it with a plastic bag. We will cover it with a plastic bag so that it does not desiccate. So the answer here is both. By using this method, we are actually trying to prevent desiccation. We are also preventing the development of abdominal compartment syndrome. The development of abdominal compartment syndrome also. Fine. So the silo method is used for treating gastroschisis, fine, to prevent both these complications, to prevent both of these complications, right? Kindly allow me to move forward. Yes, because it is copied from another file. 24-year-old patient presents with history of bleeding per rectum associated with constipation. The blood was bright red in color and was seen coating the outer surface of feces. Likely diagnosis. Yes. What is the likely diagnosis? Please reply on Telegram. What is the likely diagnosis? C. Okay. Why not internal hemorrhoids? Why not internal hemorrhoids? Answer is correct. Answer definitely is correct. It is C only. But why not internal hemorrhoids? Why the answer is not internal hemorrhoids? So, you see, your patient actually has acute anal fissure. Acute anal fissure. So, there is pain, there is bleeding, and the bleeding is on the surface of stools. Also, you get to see a cano shaped ulcer. Cano means like a boat. Cano means like a boat. Fine. Cano shaped ulcer. If it is chronic anal fissure, if it is chronic anal fissure, then you will also have sentinel tag, sentinel tag at the end of the ulcer, at the end of the ulcer. Fine. Now, what is the treatment? What is the treatment? You can use calcium channel blocker gels. For example, you can use diltiazem gel. You can use nitroglycerin gel. Can use nitroglycerin gel. What is the surgical treatment? Surgical treatment is lateral anal sphincterotomy. Lateral anal sphincterotomy. Fine. Why it is not hemorrhoid? Why it is not hemorrhoids? Because in hemorrhoids there is bleeding, and bleeding is called as splash in the pan type of bleeding. It is typically called as splash in the pan type of bleeding. Splash in the pan type of bleeding. Fine. Usually there is no pain. Usually there is no pain. Fine. Now, in the topic of hemorrhoids, what you should need to remember is what is the treatment of first degree hemorrhoids. First degree hemorrhoid, the treatment is injection sclerotherapy. What is the treatment of second degree hemorrhoid? It is, you have to remember the name. The treatment is Baron bending. Baron bending. Fine. Yes. The treatment of third and fourth degree hemorrhoid is surgery. Surgery. Fine. So, the name of the surgery, you can perform Milligan-Morgan operation, that is open hemorrhoidectomy. Open hemorrhoidectomy. You can perform Ferguson hemorrhoidectomy, that is closed hemorrhoidectomy. Fine. And then this is the preferred operation. longo operation. Longo operation is stapler hemorrhoidectomy. Stapler hemorrhoidectomy. About the external hemorrhoids. What is the other name of external hemorrhoids? External hemorrhoids are also called as 5 days piles. They are also called as Saturday night piles. They're also called as Saturday night piles. Why? Because they are excruciatingly painful. They occur with constipation. They occur with constipation. Fine. And also the next thing there, they are self-limiting or may require a cruciate incision to drain the accumulated blood. To drain the accumulated blood. Fistula will have an external opening and it will have an internal opening. Let's finish the question first, then we can discuss more of this. Yes. So now that's a CT scan finding. That is a CT scan finding. Can you check what kind of finding is this? What kind of finding is this? The one which is described by the arrow. No, this is not the question. The question is on the next slide. The question is on the next slide. But because the finding is so typical, so I thought maybe you guys can just check what it is. Or shall I give you the question? Yes, this is the question. Please have a look at the question. No. 45-year-old male presented to casualty with complaint of pain abdomen and obstipation for 1 day. As a part of his workup, a CT scan was done which returned the following picture. So this is an image of intussusception. Have a look at it again. This is a picture of intussusception. See, there is a big outer ring and then there is a small inner ring. So the answer would be polyp. The answer would be polyp. Intussusception. The answer is polyp. Fine. Target sign. Exactly. Target sign. Many of you, they often ask me, not many, but at least some, they often ask me how to determine the level of CT scan. What do you get to see over here? The pelvis. If it is the liver area, you will get to see ribs like this. Because you are getting to see the pelvis around. Fine. Pelvic bone. So that means we are entered the zone of pelvis. Fine. In the iliac fossa. So this is intussusception. And it is most likely caused by polyp in adults. Fine. So you have to identify what is this. What is this instrument? Easy question. Now, identify the following medical device. Dr. Just Chandrika, Dr. Abhishek, you're trying to answer. No, no. I'll show you what the Salem stump slave tube looks like. So this is how it looks like. Salem stump tube. This is evolved tube. This is evolved tube. This is evolved tube, which is used for removing the bezoars. Evolved tube, which is used to remove the bezoars. Remove the bezoars. Fine. So the bezoars, common in females, common in psychologically impaired individuals. It is common in gastroparesis following surgery. Common in gastroparesis following surgery. Fine. So it could be trichobezoar, where there could be hair. It could be phytobezoar, where there could be vegetable matter. Fine. It could be lactobezoar in the formula fed children, commonly used in the formula fed children. Fine. Or it could be any other type of beeswax. Fine. It could contain multiple or mix of these substances. Fine. What do How do we confirm the diagnosis? Investigation of choice to confirm the diagnosis is endoscopy. Investigation of choice to confirm the diagnosis is endoscopy. Treatment is enzymatic digestion and removal with the help of evolved tube. Removal with the help of evolved tube. This is how we can remove. Fine. So what do we use? We use enzymes like papain, chemopapain, and acetylcysteine to digest the bezoar, and then it is sucked back. Fine. Now you see here, that is why this arrangement is there. Sorry. That is why this arrangement of bulb is there. So that will maintain a pressure. Fine. It can be sucked out. It can be easily sucked out. We move to the next question. Yes. Read this question for let's say 1 minute. So 42-year-old women presents to surgery OPD with a 2-month history of dyspepsia, early satiety, weight loss. She has been unsuccessfully treated with proton pump inhibitors for 2 weeks. An endoscopy was advised, which reveals an inconspicuous esophagus, normal. Gentle folds were there in the whole stomach, and it shows no sign of tumor growth. Further, the duodenum is also normal. Read this line. Answer lies here. Answer lies here. If you don't read this last line, the answer would become Menterier disease. Fine. But read the last line and give me the right answer. Read this line and give me the right answer. Give me the right answer. Any one of you wants to differ while you are reading the last line? Yes, now the answer is 4. Now the answer is 4. See, why did I apply a cross over here? Why did I apply a cross over here? Because the patient is suffering from carcinoma stomach, which is more common in males, which is more common in elderly. But this variant, Linitis plastica, this can strike at any age. Remember the carcinoma stomach having leather bottle appearance. Leather bottle appearance. Fine. That is why this answer is there. That is why this word is there. Stomach cannot be unfolded after insufflation during endoscopy, because patient is having leather bottle like stomach. Leather bottle like stomach. Let's see what other things they support the diagnosis of carcinoma stomach. 2-month history of dyspepsia. See, what do you get to see in the carcinoma stomach? In the carcinoma stomach, there will be history of recent onset dyspepsia. That is very well there. That is very well there. Recent onset dyspepsia. Because in Linitis plastica, the stomach capacity is decreased. Your patient has early satiety. Cancer will cause cachexia. Cachexia means the patient will not feel like eating. So your patient will have history of weight loss. History of weight loss. Fine. Now she has been unsuccessfully treated by proton pump inhibitors for 2 weeks. That could have corrected if it would have been any kind of gastritis. Fine. It would have at least given her some kind of symptomatic relief. Some kind of symptomatic relief. Fine. Inconspicuous esophagus, nothing is there. Now giant fold, that could be because of Menterier disease. That could be because of Menterier disease. But here our diagnosis folds more towards the carcinoma stomach, because of the last line, which clearly says that your patient is actually suffering from carcinoma stomach. Fine. Just a minute, let me ask you one or two more questions over here. Okay, I'll ask the questions later. First, let's finish this. There are some questions here, then I'll ask some more questions, then I'll take up your queries, and you can send your queries along also. Yes, so there is a question on the next slide. There's a question on the next slide. First, have a look here. Answer it, please. No, trotters triad. Trotters, we are not going to even discuss over here. Trotter triad, remember, it is seen in nasopharyngeal carcinoma. It is seen in nasopharyngeal carcinoma. The answer is Tillock's triad. Answer is Tillock's triad. Fine. We'll discuss all of these. We'll discuss all of these here. But first we discuss what is Tillock's triad. Fine. Tillock's triad. Anyone? Dilophoid triad is seen. See, this I told you, this is seen in nasopharyngeal carcinoma. So this is out of our domain. Fine. Dilophoid triad. Can anyone of you please tell me where do we get to see the dilophoid triad? I'll write it over here so that you can easily understand. Where do we get to see the dilophoid triad? No, bhai. I'm talking about the dilophoid triad. Yes, 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 yes. Who gave the right answer? Kritarth gave the right answer. So there will be tenderness, there will be guarding, and there will be hyperesthesia. And this is classically seen in acute appendicitis. There will be classically, that will be classically seen in acute appendicitis. Acute appendicitis. Fine. Now, when we talk about the triad of Sandblom, any one of you, where is the triad of Sandblom seen? And what is the other name of triad of Sandblom? What is the other name of triad of Sandblom? So triad of Sandblom or Sandlom is seen in hemophilia. Triad of Sandlom is seen in hemophilia. Fine. So there will be pain, jaundice, and melena. So it is also called as Quincke. Also called as Quincke triad. Quincke triad. Fine. Quincke triad. Yes, it's also called as Quincke triad. Now we come to this Tillock's triad. What is there in the Tillock's triad? You see here, there will be an abdominal swelling. Fine, that is the first thing. Second, if you do percuss over here, it will give you a dull note because it is liquid, and you know it is surrounded by intestine which has air, so which will give you resonant note if you do the percussion. Secondly, you can see that the swelling can move in this direction, but the swelling cannot move in this direction. Swelling cannot move in this direction because it is fixed to the base of mesentery. It is fixed to the base of mesentery. So, Tillock's triad, there will be an abdominal swelling. So, there will be zone of dullness, surrounded by a zone of hyper resonance, surrounded by a zone of hyper resonance. Fine. Third, swelling can be moved perpendicular to the base of mesentery but not along it. So the mesenteric cyst most common mesenteric cyst happens to be lymphatic cyst and the treatment is excision of the cyst. Fine. The second most common is interogenesis. Fine. Now here the treatment cannot be excision. So excision, that means enucleation. Enucleation means simple removal. Enucleation is not possible, you know it, since blood supply of the cyst and intestine is same. Fine. Because their blood supply is same, therefore the treatment is resection anastomosis. The treatment is resection anastomosis. You cannot do the simple enucleation over here, right? That is the Tillock's triad. Okay. Now you have to identify what type of hernia is there. You have to identify what type of hernia is there. Again, this is a typical one-liner question. So one-liners are still not out. So it is a Litter's hernia, typically because it has a diverticulum arising from the anti-mesenteric part. Fine. It could be Litter's hernia. Why it is not Richter's hernia? Because Richter hernia usually is strangulated. Fine. Let's quickly see the different type of named hernias. Fine. So midal hernia is hernia with double loops. Fine. Gibbon hernia is hernia with hydrocele. Amaiand hernia is the hernia which has vermiform appendix. Fine. Now, yes. What is Stammer's hernia? Anyone? What is Stammer's hernia? Anyone, please? Stammer. Oh, screen is gone. What is stammer hernia? So stammer hernia is a type of internal hernia. It is a type of internal hernia associated with gastrojejunectomy. So it occurs through the transverse mesocolon. It occurs through the transverse mesocolon. Transverse mesocolon. Fine. Now, what is sportsman's hernia? What is sportsman hernia? Fine. So, it is common in the sportsman engaged in games which require rapid change in position. For example, rugby. For example, rugby. Fine. So there is a defect. There is a tear in posterior wall. How can you diagnose? Investigation of choice is MRI. Investigation of choice is MRI. Investigation is laparoscopic hernioplasty. The problem is that this is painful, and hernias usually they are not painful. Hernia usually they are not painful. Fine. If the hernia is painful, it is either due to strangulation, fine, or when the hernia is about to develop. At that time, the hernia is usually painful. Otherwise, the hernia is not painful. Yes. So you have to identify what is the problem, what is the pathology in this picture. Spend some time, 20-30 seconds. Look at all the landmarks there. Look at all the landmarks. Yes, this is the question. Please try to answer this question now. Okay. So why it is an indirect hernia and why not a direct hernia? See, the answer is that it is a direct inguinal hernia. It is a direct inguinal hernia. Pantaloon hernia means direct plus indirect inguinal hernia. Direct plus indirect inguinal hernia. Fine. Now you see here. You see here. If you can see it clearly, this is the medial side. This is the lateral side. How can we say that this is the medial side, this is the lateral side? See, if let's say here is the deep inguinal ring and the vas deferens is coming inside, it has to open. It has to open in the midline. It has to open in the midline. Vas deferens has to open in the midline. Fine. Where with, okay, you tell me this answer also. Where will the vas deferens open? Where will the vas deferens open up? What is the name of that point where the vas deferens will open up? where the vas deferens ends. It starts from the testis. Where does this end? Vas deferens. There is a single point and the name starts with V. V. Anyone please? Where does the vas deferens end? Dr. Ashwini, you're trying to answer. Try it. So the vas deferens ends at verumontanum. It ends at verumontanum, which is a midline structure. Verumontanum, that is a midline structure. Fine. Now you see here the vas deferens is going towards the medial side. That means this is the medial side. Fine. Now this is an inferior epigastric vessel. Anything which is medial to the inferior epigastric vessel, this is going to be a direct hernia. Anything which is lateral to it, it is going to be indirect inguinal hernia. It is going to be indirect inguinal hernia. And how do we confirm that this is the lateral side? You see this structure, testicular vessel. Testicular vessel has to join inferior vena cava on the right side. On the left side, it has to join the renal vein. In both cases, it has to go laterally. It has to go laterally. That means clearly your patient is suffering from direct inguinal hernia. What is the name of this defect? What is the name of this defect through which the hernia is occurring? What is the name of this defect? Again, that is a typically childish question. So this is a Hazelback's triangle. Hazelback's triangle. Fine. So what I'll suggest is that we just have a look at the slides of hernia. It won't take more than 4-5 minutes, but we'll be able to see all the slides of hernia, and a small topic like hernia will be able to cover with definite certainty. Fine. Very small topic. We'll just have a look at the slides. We'll just have a look at the slides. Fine. Okay, you keep on answering this question. You see your patient here is suffering from congenital diaphragmatic hernia. What is the most common cause of death in congenital diaphragmatic hernia? That is a different question. What is the most common cause of death in congenital diaphragmatic hernia? This is the question. Most common cause of death in congenital diaphragmatic hernia. Yes, give me the right answer there. Yes, so the answer is pulmonary hypoplasia. Pulmonary hypoplasia, that is the most common cause of death. Fine, that is why you see bag and mask ventilation. Bag and mask ventilation is contraindicated. Contraindicated. Fine. Bag and mask ventilation is contraindicated. One thing there. So Dr. Ashwini says, let's call this BMV. So BMV is bag and mask ventilation. Fine. Please tell me, Dr. Ashwini, bag and mask. Dr. Kritarth also. Any one of you, Dr. Ashwini or Dr. Kritarth. Sorry, it's Dr. Ashwini 2.0. भाई ब्रेकअप हुआ था क्या जो 2.0 रख लिया नाम? Bag and mask ventilation is also सत्तू तो नहीं बन जाओगे सत्तू भाई, आईएएस बन के आ जाओगे कल को. Bag and mask ventilation is also contraindicated in, yes, Tell me the answer. This is also contraindicated in. Yes, it is contraindicated in diaphragmatic hernia, but what other condition is the bag and mass ventilation contraindicated? So it is also contraindicated in tracheoesophageal fistula. It is contraindicated in tracheoesophageal fistula. Fine, tracheoesophageal fistula. Right. So you see here, there is pulmonary hypoplasia that can cause death. So it is more common on the left side, more common on the left side. Fine. Now please tell me, what is this hernia called? What is the hernia called if it occurs on the right side? What is the hernia called if it occurs on the right side? Right side hernia. Which hernia? Okay. Nevertheless, my salute. You want to say breakup नहीं हुआ डॉक्टर अश्विनी? So right side hernia is called as Larry hernia. Larry hernia. Fine. Carry on. Right side hernia is called Larry hernia. Right? Congenital diaphragmatic hernia. From the right side, pleuroperitoneal canal. Fine. And this should always be repaired with a mesh. Right? Okay. Hiatus hernia. Hiatus hernia. Okay, can anyone tell me what is the most common type of hiatus hernia among those which are seen there on your screen? What is the most common type of? So there's a new Playboy going to be in the market after the internship. So this is the most common type. Which of the hernia has got the risk of complication? Which of the hernia has got risk of complications? Maximum complication here and this. Fine. This. What is the name of ulcer? What is the name of ulcer that develops in this hernia? What is the name of ulcer that develops in this hernia? Name of ulcer that develops in this hernia. So hiatus hernia may be associated with Cameroon ulcer. May be associated with Cameroon ulcer. Cameroon ulcer. Cameroon ulcer is a longitudinal ulcer. Is a longitudinal ulcer. Fine. Which of the hernia is associated with cardiac arrhythmia? Which of the ulcer, which of the hernia is associated with cardiac arrhythmia? Cardiac arrhythmia. अरे डॉक्टर निखिल, आप ये क्या गोभी भेजते रहते हैं? 2 बार आप गोभी भेज दिए. पहले 1 फूल भेजा था, अभी 2 फूल भेज दिए. ब्रोकली. ओके ब्रो. अरे मिडिल क्लास आदमी को कहाँ ब्रोकली दिखा रहे हो यार? क्या बात कर रहे हो? मुझे तो गोभी किसी दिन 25 की जगह 30 की किलो मिल जाए, मैं वो छोड़ देता हूं, तो मुझे ब्रोकली दिखा रहे हो 180 वाली. So this type of hernia is associated with cardiac dysarrhythmia. Fine. So this is common in elderly. This is common in elderly. मैं भी नोट किया अभी, मैं भी नोट किया अभी. ब्रोकली, गुड. आई जस्ट हैड इट वंस. वो खाने की तरह नहीं, चखने की तरह खाया था ब्रोकली. राइट. Thank you. Okay, what is the most common complication of Nissan's fundoplication? What is the most common complication of Nissan fundoplication? Wow, so I need to be there at Gautam Nagar. बाहर पुलिस खड़ी है, पता चले ब्रोकली के चक्कर में कुछ और बन गया. No. Flatulence. Flatulence is the most common complication. Flatulence. See, let's say you drink an aerated drink. Doctor, I didn't want to comment there, but then you did it. So you see what happens is that whenever we have something aerated drink like Pepsi, so it can go up. Fine, but whenever there is fundoplication, it cannot go up. So the gas will ultimately go down to cause flatulence. Will ultimately go down to cause flatulence. Fine. Okay. Very quickly. So you must be aware about the Nyhus classification, because this is will be going too deep. So I'll just recommend you to read the Nyhus classification. Fine. And then the Gilbert classification. See, Gilbert classification is comparatively easy. Gilbert classification is comparatively easy. Small, medium, large. And then it is entire flow. Fine. You can also remember it as indirect. Then there is direct. Fine. And then there is pantaloon hernia also. And last it is femoral. Fine. So it's not being routinely asked. What classification is being routinely asked is this: European Hernia Society classification, that is commonly being asked. Fine. So if they say you in the examination that yes, your patient suffers from PL2 hernia. What do you mean by PL2 hernia? PL2 hernia means your patient suffers from a primary hernia. Your patient has an indirect hernia. Fine. And the hernia is very wide. That means around 2 fingers can easily go inside. Fine. Here, you must keep in mind that the word R means recurrent hernia. It does not mean right or left side. Doctor, Gilbert is not syndrome. Gilbert is just classification. See, I told you, it is not very easy to remember, and it is not very important to remember also. What is important to remember is this classification. This is called as European Hernia Society classification. So Gilbert is just classification of the different type of hernia. So in examination you will get a code. that your patient has RF1 type of hernia. So you have to expand what type of hernia your patient has. See R, that means your patient has recurrent hernia. F, that means your patient has femoral hernia. Fine. And one means the ring. One means the ring will just allow one finger. Will just allow one finger. Right? Will just allow one finger. So European Hernia Society classification you need to remember. Other classification, if you can recall, it's very good. Otherwise, it's not very important. Fine. Similarly, you see the Nyhus hernia. Nyhus hernia. Nyhus hernia is even simple if you look at deeply. Normal deep ring, dilated deep ring. Fine. Now, this will include very wide ring. So it could be direct hernia, it could be both, it could be femoral. Only if you can remember, otherwise it is not very important. Fine. Let's move forward because I want to discuss the laparoscopic hernia. So this is the material for the standard class. So this is typically Richter hernia. What is Richter hernia? This part will be strangulated. This part will be strangulated while there will be no obstruction. While there will be no obstruction. Fine. Now, I'm going to ask you a scenario-based question. I'm going to ask you a scenario-based question. Fine. See here. So, question is, you have a 25-year-old male patient. 25-year-old male patient with right inguinal hernia. Right inguinal hernia. Fine. On examination, the patient is clinically febrile. That means the patient has fever. Fine. The patient gives no history of obstipation. Patient gives no history of obstipation. That means patient is not passing, patient does not give any history of constipation or obstruction of the flow of gas. Fine. When you do the local examination, the site is exquisitely tender. Site is exquisitely tender. Fine. Blood investigation. Blood investigation. Fine. Your patient has TLC count of 22,000. DLC count is 80, 18, 1, 1. That means 80% neutrophils, 18% lymphocytes, 1% basophil, 1% eosinophils. Fine. Now, you have to make a diagnosis. Give me at least 3 diagnoses. Give me at least 3 diagnoses. Any one of you, please. It is in front of you. 25-year-old male. Now just give me one answer. Can it be strangulated hernia? Can it be strangulated hernia? I'm waiting for your answer, please. When you guys were discussing broccoli and all other stuff, at that time you were typing very, very quickly. Now when it is the turn to give answer, now you are not typing. Okay. What gives you the hint that it is a strangulated hernia? What gives you the hint that it is a strangulated hernia? So you see, this thing indicates strangulation. This thing indicates strangulation. This thing indicates strangulation. Fine. Now, no history of obstipation. no history of obstipation. This goes strongly against strangulation, because in strangulation, fine, obstipation should be there. Obstipation should be there. Fine. Now, one diagnosis is that your patient has Richter's hernia. Your patient has Richter's hernia. Fine. Now, the second diagnosis you can obtain from this keyword, and second diagnosis you can obtain from this keyword and this keyword. Wherever the word this is written, from there you can make second diagnosis, and also from this, please try to make a second diagnosis. Read all the word this written on the screen, and please try to make a diagnosis. What is your patient suffering from? So your patient is suffering from inflamed hernia. Fine. For example, in this case, your patient is suffering from a myend hernia. That means inflamed appendix is present. That is why there is no obstipation, and that is why there is local tenderness. Fine. So we move to the next thing there. So this is midal hernia. So in midal hernia, the common question they ask you is, which loops gets strangulated? So of course it is the inner loop which gets strangulated. Fine. Hernia NW. Now this is the Hazelback triangle through which direct inguinal hernia appears. Right. I'm moving forward there because we cannot spend so much time over there. Now, I want you to see all kind of repair along with their name. So if you just do closure of the inguinal ring and no other repair, this will be called as Marcy repair. Fine. Bassini repair and Schuldes repair. What are they? They are a type of herniorrhaphy. Fine. Lothisan, when you repair the Cooper's ligament. So this is not very important. Fine. See, this is the Marcy repair. So if you narrow the internal ring, it is called as little repair. This is Bassini repair. I'll share this PPT also. Bassini repair. Now, this can be asked in the question. This can be asked in the examination. Why? This is Schuldes repair. So what do you do in Schuldes repair? So you perform double breasting. Whenever the needle goes like this, you see we have 4 folds now. Schuldes repair, double breasting of transversalis fascia. Enough of hernia. Last 1 or 2 minutes of hernia. Yes, this is important. Fine. So when you are performing laparoscopic surgery, you place the mesh in the preperitoneal layer. So you need to be aware about these 2 spaces and their name. So this is the space of Retzius. This is the space of Boggross. Fine. Also, here you place the mesh. Also, you need to know about these two triangles. These two triangle. First is the triangle of doom. If you apply any of the tack over here, patient may die. So his life is doomed. The surgeon's life is also doomed. Fine. Next is the triangle of pain. Triangle of pain. Fine. Like, see, the triangle of pain will be seen laterally. Triangle of doom will be seen medially. So triangle of doom has got iliac vessels, while the triangle of pain has got many nerves. Triangle of pain has got many nerves. Fine. So this is where you place the mesh. Can any one of you please tell me which is the most commonly injured nerve? Most commonly injured nerve during laparoscopic hernioplasty. So most commonly injured nerve during laparoscopic inguinal hernioplasty is lateral cutaneous nerve. During open hernioplasty, it is the ilioinguinal nerve. So the nerve which is behind the mesh, which is trapped behind the mesh, is iliohypogastric. Iliohypogastric. So these are the nerves whose names you must be knowing. Any of one of you want to solve this question? So this is for regular class. Just spend 1 minute on reading the statement. Just spend 1 minute. Again, I told you this question, moderate difficulty. This question is having moderate difficulty. Moderate difficulty question. So, elderly patient, emergency department, incarcerated means obstructed femoral hernia, may undergo strangulation, but he takes warfarin, past history of atrial fibrillation, INR 3.1. Which of the following is the correct statement? First of all, you must note that INR, international normalized ratio, is prothrombin time of the patient divided by prothrombin time control. That means the normal prothrombin time. So it should be less than 1.4 for any surgery. It should be less than 4 for any surgery. Let's see what is the patient. So this, admit the patient for correction of INR and repair of hernia in the morning is wrong, because by the time strangulation will develop, perform an emergency laparoscopic hernia. No, there will be too much bleeding, because high INR means the patient can bleed like anything. Patient can bleed like anything. Perform an emergency open repair of the hernia. This is good. This is a good stage. Fine. Open repair you can do. Open repair you can do. Attempt a reduction of hernia in the emergency department. No. This is called as Texas. So Texas should not be done in case of obstructed hernia. Fine. Use a mesh. If there is risk of strangulation, this is important. If there is risk of strangulation, no mesh is to be used. If there is risk of strangulation, no mesh is to be used. Fine. See, earlier also, Earlier also they used to ask you this question in one-liner format. Remember, there was a very favorite question of the teachers. What is the surgical treatment of choice in strangulated inguinal hernia? Yes, what is the treatment of choice in strangulated inguinal hernia? The treatment of choice is Bassini repair. What is the treatment of choice in inguinal hernia? In children, it is herniatomy. In adults, it is Lichtenstein operation. It is Lichtenstein operation, that is hernioplasty. That is hernioplasty. But hernioplasty always includes mesh. We cannot use mesh over here. We cannot use mesh over here. So the questions are the same, but now they have started asking the questions in a different way. Now, apart from doing the option C, what else will you do in this patient? What else will you do in this patient so that this patient does not bleed? What else you will do so that this patient does not bleed? Anyone? See, what I'm trying to ask is, what is the antagonist of heparin? We know that it is protamine sulfate. We know that it is protamine sulfate. What is the antagonist of warfarin? What is the antagonist of warfarin? I have been getting this answer, vitamin K, but you have read another line somewhere. What is used for rapid reversal of warfarin? What is used for rapid reversal of warfarin? You have been using fresh frozen plasma. Fresh frozen plasma. Fine. So give your patient fresh frozen plasma and everything will be all right soon. Fine. We know that 1 unit of fresh frozen plasma, it raises clotting factor levels by 3%. Clotting factor levels by 3%. Fine. So you may give your patient fresh frozen plasma and maybe your patient will eventually recover. Fine. Now, I'm going to make a statement and you have to tell me whether the statement is correct or not. Giving fresh frozen plasma can make laboratory values of clotting profile normal again. Is this statement correct or incorrect? Giving fresh frozen plasma can make laboratory value of clotting profile normal again. Is this correct or incorrect? So, fresh frozen plasma cannot make lab values normal. Cannot make lab values normal. Cannot make lab values normal ever again. So let's close this slide. Let's close the topic of hernia. Let's move to the other things. Let's move to the other things. Is that slide gone? Yes. Let's move to the other question. Yes. Okay. 55-year-old female. After this, maybe we can take a 10 minutes break. 55-year-old female presented to surgery OPD with complaints of a non-healing ulcer over her right leg. Detailed history revealed that she is suffering from rheumatoid arthritis and is not taking any treatment for her condition. Local examination revealed that local temperature is mildly raised. Optimum treatment option for the condition. Yes, anyone please. Okay, first of all, what is the diagnosis? What is the diagnosis? These things will lead you to diagnosis. So, in this case, your patient is actually suffering from pyoderma gangrenosum because it is a long standing ulcer. So, antibiotics will not help because the patient is suffering from rheumatoid arthritis. So there would be associated vasculitis. There would be associated vasculitis. Fine. Hence, the treatment would be giving your patient corticosteroids. Fine. Or you can also use cyclosporin. You can also use other kind of chemotherapy drugs. You can also use other kind of chemotherapy drugs. Fine. Yes. Please give me an answer to this question. See the word leather like, no blister, little pain, fine, no bleeding. That typically indicates that your patient has third degree burn. Third degree burn. Fine. Third degree burn. Fine. Leather like. That means your patient has eschar. We read it yesterday. We read it yesterday in detail, but yesterday you guys were in the bad mood. So that is why maybe you could not remember it correctly. Partial thickness superficial burns. They have thin wall blister which has clear fluid. Partial thickness deep. They have thick wall blister with turbid fluid. With turbid fluid. Only the full thickness, it does not have any blister. Does not have any blister. Superficial also does not have any blister. But there, the pain is severe. The pain is severe. Fine. So, your patient probably suffers from full thickness burns. Probably suffers from full thickness burns. Right. So, let's take a small break. So by my watch it is 2:50. Let's assemble at 3:05. I've got another class coming up and I need to make some important phone calls. So let's take a break. The break was nevertheless due. I hope that's okay with everyone. Right. See you again shortly. We are done with very little questions. We are left with only 10-15 questions we are left with. चार बजे के आसपास कॉल करके आपसे डिटेल ले लूँ, ये भी क्लास शुरू हो रही है। मैं 4 बजे के आसपास आपको कॉल करके डिटेल ले लूँ आपसे। Right, kindly allow me to start. तुम लोग क्या क्या बातें करते रहते हो आपस में? A nice GF, Sriniji. It is it is there. Yes. So please tell me the answer to this question if you guys can hear me. Am I audible? Screen visible? Please tell me the answer to this question. Okay, so answer to this question. No, no, no. That's an old concept. That's an old concept. When you say no, that means it is an old concept. So according to ATLS 10th edition, now eFast can be used. eFast can be used to confirm the diagnosis. Why eFast can be used? Why eFast? Fine, because it is bedside assessment. It can be done bedside. Patient doesn't have to move here and there. Deep vein thrombosis. The treatment should continue for deep vein thrombosis. So the treatment should continue for at least 3 months. Treatment should continue for at least 3 months. Fine. 12 weeks. Deep vein thrombosis. I want you to have a look at the images. Deep vein thrombosis. Remember what are the risk factors for the deep vein thrombosis? What are the risk factors for deep vein thrombosis? See, it is the Virchow striad. Fine. So hypercoagulability, vessel wall injury. Fine. And then there is stasis. I want you to analyze some of the images. See, so what is this clinical test? Because in the last examination they asked some of the clinical tests. So what is this Homan sign? There will be pain on the passive dorsiflexion of foot. Pain on the passive dorsiflexion of foot. Fine. What kind of sign this is? This is a very bad sign because this has very low sensitivity and very low specificity. That is why it is called non-reliable, totally non-reliable sign. Fine. Lowenberg test. Fine. So Lowenberg test is used with the help of BP cuff. Lowenberg test used with the help of BP cuff. Fine. So there will be pain as soon as the pressure rises. Pain as soon as the pressure rises. Mohs test. There will be pain and tenderness when we squeeze the calf muscle. Pain and tenderness when we squeeze the calf muscle. Now, phlegmasia alba dolens, called as milk leg syndrome. Fine. So there, what will happen there? Deep veins blocked. Superficial vein, collateral veins, they are open. Fine. Cerulean, painful blue legs. Fine. Both are blocked. Superficial as well as deep. Both are blocked. Fine. Both deep and superficial veins, they are blocked. Fine. Now it's a surgical emergency. This is the appearance when we remove the thrombus surgically. Fine. Now, if you can remember, if you can watch this thing, the third image, we know that the daily some part of thrombus will detach. We just need to make sure that new thrombus does not form. So that is why what we do. As a part of treatment, we give our patient low molecular weight heparin for 5 days. Fine. And then we start warfarin as early as possible. Fine. Now this is given for minimum 12 weeks. In the first instance. If DVT is recurrent, warfarin is continued lifelong. Find deep vein thrombosis. Okay. What is the best prophylaxis for DVT? Best prophylaxis for DVT is pneumatic compression. Fine. Otherwise, you can also use Low molecular weight heparin. Low molecular weight heparin. Fine. Now let's have a look at some of the images. Some of the images. So, can anyone tell me what is this? What are these? So these are spider veins. These are spider veins. Spider veins. So that means varicose veins are about to start appearing. They are about to start appearing. Fine. What is this? Corona phlebectasia, like this. Radiating veins. Corona phlebectasia. Fine. So this sign is called corona phlebectasia. Saphenous fine, dilated end of the saphenous vein, dilated end of the saphenous vein. Now, if saphenous is present, it is called as Curviller sign. It is called as Curviller sign. So you see, dilated end of the saphenous vein, Curviller sign. Champagne bottle sign. It is also called as inverted beer bottle sign. Also called as inverted beer bottle sign. Fine. Brody Trendelberg test type 1 and type 2. So we know test 1 is for saphenofemoral junction incompetence. Test 2 is for perforator incompetence, right? What is this test being performed? So you see, this is Schwartz test. This is Schwartz test. Morrissey cuff test. When the patient will cuff, the vein will appear. The vein will appear. Morrissey cuff test. Fine. This is the best test. Perthes test. So whenever you see a tunique, this is called modified Perthes test. Important, must read. Now, any one of you, would you guys like to solve this question? There are some questions here if you want to solve. Just a minute. Yes. What is the most common cause of death in a patient of Berger disease? Berger disease, which is also called as thromboangiitis obliterans. Anyone? Most common cause. Remember, Berger disease patients, they are smokers. Berger disease patient, they are smokers. And smokers, they are at the risk of ischemic heart disease. So they commonly die from myocardial infarction. They commonly die from myocardial infarction. Fine. So Berger disease, it is common in 20 to 40 years of age, common in males, common in smokers, common in Indians, common in Jews, common in poor people, low socio-economic strata. Fine. Small, it will affect small and medium size arteries. Small and medium size arteries. If you can remember, what are the clinical feature? The claudication, rest pain, ulceration, and gangrene. These are the clinical feature. What are the classification methods we use? We use Boyd classification. We use Fontaine staging. Remember what is the investigation of choice. Investigation of choice is arteriography. What is the treatment? In the treatment, we use vasodilators. For example, xanthinol nicotinate. Xanthinol nicotinate. Fine. Also, we can perform lumbar sympathectomy. Lumbar sympathectomy. Can any one of you tell me what is the drug of choice to quit smoking? Drug of choice to quit smoking. Drug of choice to quit smoking. Bupropion. Fine. Earlier it used to be varenicillin. But now it is considered to be bupropion. Yeah, Dr. Mr. 2. Nicotine chewing gums, they don't help. Personal experience. They don't help. So we have to go in for bupropion. Right? Now, your patient can have claudication plus erectile dysfunction. Yeah, they don't help, but you see the slogans they do help. You know, when someone asks you to quit smoking, वो slogan चिपका दिया करो. Everyone says that the smoking kills, but there is something which is already killing the smoker. Fine. So you just make an emotional appeal. So next time they won't ask you to quit smoking. So Leydig syndrome is claudication plus erectile dysfunction. पापा वाला हेल्प नहीं चाहिए भैया, बड़े जोर से पड़ती है वो. Yes, anyone please. Lumbar sympathectomy, L1 ganglion removal on both sides. L1 ganglion removal on both sides. What will it cause? L1 ganglion removal. No. See, remember the mnemonic. Point and shoot. P for parasympathetic nervous system. S for sympathetic nervous system. Point means parasympathetic nervous system is responsible for erection and sympathetic nervous system is responsible for ejaculation. So after you remove L1 ganglion on both sides, your patient will not be able to ejaculate normally. So practically he may become sterile. Fine. Okay, sequence of color changes. Now that's a very easy question. Sequence of color changes in Raynaud's disease is. Yes. So it is earlier going to be white, then it is going to be blue. Fine. Now tell me, which has better prognosis? Primary Raynaud's syndrome or secondary Raynaud's syndrome? Which of these has better prognosis? Primary or secondary? Primary Raynaud's syndrome has better prognosis. So primary Raynaud's syndrome, which is also known as Raynaud disease, more common, 90%. It occurs in younger individuals. Fine. Better prognosis, idiopathic, we don't know what causes the disease. Fine. Both are common in female, and people using vibrational hand tools, like the typewriters, like the drill machines. Fine. And also in labile individuals, emotionally labile individuals. Fine. What are the different treatments? Different treatments. Calcium channel blockers, they are the drug of choice. You can use evening primrose oil. Fine. You can use botulinum toxin. You can use botulinum toxin. Fine. You can use PDE5 inhibitors, phosphodiesterase 5 inhibitors like tadalafil, sildenafil and all. Fine. You can use ascorbic acid, and if nothing works, you can use thoracic sympathectomy. You can use thoracic sympathectomy. Right. Now, last question here. In pregnancy, the changes associated with Raynaud's syndrome. The changes associated with Raynaud's syndrome, what happens to them? Changes associated with Raynaud's syndrome. Remember, pregnancy is a phase of progesterone, and progesterone is a relaxing hormone. So everything will relax. Fine. Even the blood vessel will relax. Therefore, the changes will improve. Changes associated with the Raynaud's syndrome, they will definitely improve. Fine. Now let's go back to the question. If we are left with some time, we can always come back here. Commonest cause of abdominal aortic aneurysm is? Commonest cause of abdominal aortic aneurysm. Answer would be atherosclerosis. Atherosclerosis. Fine. When we talk about the abdominal aortic aneurysm, you need to be aware about these things. Crawford classification. Fine. Crawford classification of the aneurysm. Don't go into the details. Just remember the name. Fine. You also need to be aware about these two maneuvers. Fine. Mcqs maneuver and also the Kettle-Brash maneuver. So Mcqs maneuver is done on the left side. Fine. To expose the structure in the retroperitoneum. Mcqs maneuver. Some people also use the word D instead of T. Mcqs maneuver. Fine. So we expose the aneurysm. With the help of Mcqs maneuver. Fine. We give a cut to the peritoneum over here, and the retroperitoneal structures can be easily accessed. Fine. Kettle-Brash maneuver. Kettle-Brash maneuver is used to expose the vena cava. Fine. Another thing which you should be aware is the artery of the Mcqs. Fine. So this artery can, if it is damaged, anterior spinal cord may be affected and your patient may become impotent. Fine. Artery of Mcqs. Yes. So we are left with very few questions now. Surgical procedure suffering from late stages of filariasis. Yes. Which operation are we going to use for the patient of filariasis? Anyone, please? No. See, filariasis is the most common cause of lymphedema. It is the most common cause of lymphedema. Right? Filariasis, most common cause of lymphedema. Right, just a second. So you just, so you see, most common cause of lymphedema is secondary lymphedema. Fine. Now in the Western world, most common cause of lymphedema is secondary to cancer surgeries. But here in India, most common cause is filariasis. Most common cause is filariasis. Fine. Surgery is done rarely, less than 5% of the patient. Why? Because the results are poor and recurrence is common. Result is poor and recurrence are common. So these are the different type of surgeries which we perform. Because there some of the slides are not there. Just a minute. Just give me a minute, please. So in the lymphedema, this is all what you need to remember. How does the lymphedema form? So it follows the Starling law of capillaries. Starling law of capillaries. Fine, this word is important. Starling law of capillaries. Fine. Then there could be edema and all. Now, Milroy disease is a form of primary lymphedema. Primary lymphedema. That means there is no cause. There is no cause. Fine. Now, the familial form of lymphedema precox. Lymphedema precox is the most common type of primary lymphedema, and if the disease runs in family, it is called as Mcqs disease. Now you see how it is similar to the other diseases, how it is similar to the other diseases. Fine. Other diseases, see, Meg syndrome, fine, Mcqs syndrome, and the Mcqs disease. Mcqs disease. Fine. So Mcqs disease is a type of lymphedema. Rest others are different. Rest others are different. Right. So these are the clinical features. You cannot pinch the skin. You cannot pinch the skin over the dorsum of feet. Fine. That is called as stammer sign. Fine. You see, there would be hyperkeratosis, thick skin. This all happens in elephantiasis. On the feet, buffalo hump may be seen. Buffalo hump may be seen. Now, we follow Brunner classification. Brunner classification for lymphedema. Now, these are the different operation. Either we perform bypass operation, for example, nodovenous anastomosis. We join lymph node with the vein. We join lymphatics with the vein. Fine, that is the Kinmoth operation. Fine. Or we do reduction operation, cyst trunk. We cut the extra tissue. Fine. Thompson Swiss roll. We cut the extra tissue and we twist it like this. Fine. Here, because the disease is already advanced, so we'll just cut whatever extra skin is there, and over that we will apply a skin graft. We'll apply a skin graft. That is called as Charles operation, and that is the surgery which we perform in filariasis. That is the surgery which we perform. So that was few words about lymphedema. We move to the next question. Again, we discussed this yesterday. I believe you will be able to answer this question. Please have a look and you'll be able to answer this question. No. I've asked you the least possible stage. Remember, lymph nodes 3A, 3B, 3C. Fine. So what was there? Infraclavicular, supraclavicular. Fine. So that means supraclavicular lymph nodes are always N3 lymph nodes. Remember, where did the N3 lymph node appear? The N3 lymph node appear only in the stage 3C. The N3 lymph node appear only in the stage 3C. See, this is important. Let me close this all. Close all whatever extra is open. Because this is important thing there. You don't need to remember any other stages with the greatest detail, as you need to remember the staging of breast. I told you, when we talk about N3, so N3 includes the worst lymph nodes, which carry worst prognosis. So N3A was infraclavicular lymph nodes. N3B was internal memory plus axillary lymph nodes, both. Fine. And N3C is supraclavicular lymph nodes. If you can remember correctly, what was the stage 4 of the disease? Stage 4 of the disease was distant metastasis. We are moving in the reverse direction. Stage 3C was NET. Stage 3C was NET plus N3. NET plus N3. Fine. So that means it is N3 lymph nodes. So that means your patient is in stage 3. Just to keep you away from any kind of doubt, stage 3B was T4 plus N0, N1 or N2. The idea is that N3 did not appear. N3 did not appear in the stage 3B. See, spend as much time as you can on the staging, as much time as you can on the staging. Staging of the cancer breast is extremely important. Staging of the cancer breast is extremely important. I mean, we cannot do without reading the staging of cancer breast. Fine. See, what I tell you, personal experience. First, you see, this one you can safely exclude. Stage 4, worst, इससे बुरा तो कुछ हो नहीं सकता. Stage 3C, this is also worst when the disease is so advanced. Only thing which you need to remember is stage 3A, 3B and 3C. That is the only thing which you need to remember. Only thing which you need to remember. So, T0, T1, T2, T0, T1, T2, T3 plus N2. This is your stage 3A. Such a simple thing, or T3 plus N1. So you see, I don't think that remembering stage 3 is difficult. When you don't have to remember any other staging, I think at least this much you can remember. And if you read the staging of breast, you will understand that only remembering this part is difficult. Rest of the parts are not very difficult to understand. Only remembering the stage 3 is difficult. Fine. So, because your patient has supraclavicular lymph nodes, because he has supraclavicular lymph nodes, that means N3 lymph nodes are present, and N3 lymph node, they make entry only in the stage 3C. Stage 2B not present, stage 2 not present, stage 4 they could be present. Fine, but we have asked the lowest possible stage. Fine, please just remember this. Benign hyperplasia of prostate surgery, TUIP, transurethral incision of prostate, is considered for, yes, what is the benefit? So with this question, the examiner is asking you what is the benefit of TUIP. What is the benefit of transurethral incision of prostate? Anyone? Why do we consider? Okay, so if you can tell me the most common complication of TURP, the answer will lie in front of you. What is the most common complication of TURP? Transurethral dissection of prostate. What is the most common complication? The most common complication is retrograde ejaculation. No, Dr. Akash. I'll tell you about this also. Most common complication of TURP is retrograde ejaculation. Most common late complication. Most common late complication. See, you guys have read from teacher which are considered gems. Fine. And don't give me these answers. Yeah, I mean, that breaks my heart actually to see. Because these are one-liners actually. So the most common late complication is bladder neck contracture. Now, this retrograde ejaculation can be distressing for some of the patient, especially those who are young. Fine. So, we perform TUIP, transurethral incision of the prostate. Transurethral incision of the prostate. Let's say the prostate is very small and the urethra is narrow. So what do we do? What do we do is simply make two cuts at 5 o'clock position and 7 o'clock position. Fine. So that will make the urethra very wide. that will make the urethra very wide. Fine. And the main benefit is there is no retrograde ejaculation. Unfortunately, it can be done if the prostate size is less than 20 grams. It can be done only if the prostate size is less than 20 grams. Fine. Now, for example, Dr. Akash told that water intoxication is the common problem. Water intoxication, that is called as TERP syndrome. So that means patient has hyponatremia. That occurs first if the prostate size is more than 70 gram, or if the surgery time is more than 90 minutes. What is the drug of choice? Drug of choice is furosemide. Furosemide will give our patient furosemide. Fine. Drug of choice is furosemide. Fine. Drug of choice is furosemide. Okay. What is the solute most commonly used? So we used 1.5% glycine. We cannot use distilled water because it will severely cause hyponatremia. We cannot use normal saline because it will diffuse the current. What is the common side effect of 1.5% glycine? Anyone please, what is the common side effect of 1.5% glycine? What is the common side effect? So, the metabolites are toxic to the eyes. So, common side effects are visual disturbances. Common side effects are visual disturbances. Right? Yes. So now you have to identify this device. Some of the slides are missing. I don't know how, because when I copied this from one slide to another, probably they could not be saved. Nevertheless, what is this? Can any one of you identify? Yes, this is called as DJ stent. This is called as DJ stent or DJ catheter, whatever you want to call it. Fine. So this is to be used in the ureter. Check if there are, I don't know. Nevertheless, identify. The question will be there on the next slide. Again, you can identify these are the big paraspinal muscles. See what is there. Yes, Dr. Rahul, great. So if you can correctly judge it as renal stone, can you see something else? Yes, this is renal stone. Horseshoe kidney. Your patient is suffering from horseshoe kidney. Very good. So please tell me what exactly stops the ascent of kidney. What exactly stops the ascent of kidney? Why can't the kidney reach the normal position? Which blood vessel stops the ascent? Which blood vessel stops the ascent? It is the inferior mesenteric artery. Inferior mesenteric artery. No, not the abdominal aorta. Inferior mesenteric artery. It stops the ascent. Stops the ascent. Right? Now, identify the condition which you have already done. Apart from mentioned question, the patient is prone to develop. So, in horseshoe kidney, all the complication can appear. All the complication can appear. All the complications. See, most of the patients, they are asymptomatic and they remain so throughout their life. They remain so throughout their life. Fine. But many of the patient may develop complication which include all of the above. Which include all of the above. I'm really glad that you could identify this. Very glad. The question is there. You know, the same question that the DJ sent. Yes, a 32-year-old female presented to surgery emergency with a complaint of pain, right hypochondrium for last 8 to 10 hours. On examination, she is clinically febrile. Investigation revealed increased TLC, liver function test normal, ultrasound revealed gallstones with pericholecystic fluid. Preferred management of the patient. Yes, please. What is the preferred management of the patient? Why are you guys answering two? ERCP is done for stones in the CBD, common bile duct. See, what are the catchwords there? I'll tell you what are the catchwords there. The catchwords there are last 10 hours. That means patient has come to you in less than 24 hours. So if the patient comes to you in less than 24 hours, you immediately perform cholecystectomy. You immediately perform cholecystectomy. Fine. So I believe this is the best choice. I believe this is the best choice. I mean, laparoscopic cholecystectomy without giving IV fluid, without giving antibiotics is not possible. Fine. So this is the best choice. First, this is the second best choice. Fine. Now, ERCP is done for stones in the common bile duct. Endoscopic retrograde cholecystopancreaticography. Fine. So, if patient is attended within 24 hours, the treatment is laparoscopic cholecystectomy. Fine. Now, if the patient comes after 72 hours, if the patient comes after 72 hours, fine, in that case, the treatment is interval cholecystectomy. That means we first stabilize the patient and then we perform cholecystectomy after 6 to 8 weeks. Fine. So this 24 to 72 hours. First 24 to 72 hours. But this patient, this came only in 8 hours. So this patient should be subjected to immediate surgery. Immediate surgery. Fine. What happens is when there is acute inflammation, all the abdominal organs, they come together. The surgery is not safe. After 6 to 8 weeks, they go away. Now you can safely do the surgery. But while the abdominal organs, they are coming near the gallbladder, it will take at least 72 hours. So during those 72 hours, you can perform surgery. You can perform surgery. Fine. So this is the, most of you have answered 4. Had this 8-10 hours been 80 or 100 hours, that means 4 or 5 days would have been there, then we would have preferred this option. Because the patient came too early, we'll do the cholecystectomy immediately. Middle-aged patient underwent ERCP for CBD calculi. Got the point? Now presents with fever, pain, right hypochondrium, and jaundice. Ultrasound shows hypoechoic lesion of the liver. See, this is the first catchword. Hypoechoic lesion. There is no evidence of cholelithiasis. Gallbladder acute cholecystitis is gone. So TLC is raised. Alkaline phosphatase is mildly raised. Fine. So first of all, what is this patient suffering from? This patient is suffering from PLA. That means this patient is suffering from pyogenic liver abscess. More common in males. Fine. TLC raised. Fine. Often multiple. Jaundice is present in 25% of the individual. Serum alkaline phosphatase is mildly raised. Fine. So what is the preferred treatment there? Percutaneous drainage and antibiotics. Fine. That is the preferred drainage. 45-year-old housewife living in rural household present to surgery OPD with complaint of dull pain abdomen associated with nausea. General physical examination revealed mild hepatomegaly. A provisional diagnosis was reached after performing ultrasound. Confirmation of the diagnosis can be done by anyone, please. Why not going for a simple test like ELISA? This patient is suffering from hydatid cyst. Most common clinical feature is hepatomegaly. And ELISA. See, not many of the people will have hydatid cyst. Not many of the people will have antibodies. So ELISA is confirmatory investigation. Fine. CCT can also confirm. Fine. But if we have to choose between CCT, contrast CT, and ELISA, we'll prefer to go by ELISA. CT scan performed in a post-menopausal woman while undergoing metastatic workup for carcinoma breast. She was found to harbor, spelling wrong, mistake, 6 centimeter lesion in the right lobe of the liver. Fine. On 3-phase CT is found to have features suggestive of hemangioma. So hemangioma often is just an incidental finding. Now, appropriate management. If the hemangioma is more than 7 centimeter in size, if the hemangioma is more than 7 centimeter in size, it needs treatment. Fine. Otherwise, it just requires observation. Now this is less than 6 centimeter in size. So we'll go in for observation. So the answer will be observation. Yes. What is this condition? I've got another class coming up. Yes, so first of all, what is this condition? So this patient of yours suffers from pancreatic devisum, pancreas devisum. So you see the main duct, this is the main duct. Now, main duct draining the body. So this will drain at minor papilla. This can be easily diagnosed by MRCP. This can be easily diagnosed by MRCP. So this is the investigation of choice to diagnose pancreas devisum. What is the problem with pancreas devisum? There commonly occurs repeated evidence of pancreatitis. What is the treatment is sphincterotomy. We perform sphincterotomy. So read the question. The following CT image is obtained from 52-year-old male patient. Most likely presenting complaint of this patient would be. So this is typical chain of lakes appearance. Fine. So that means your patient here is suffering from chronic pancreatitis. Chronic pancreatitis, most common clinical feature is pain followed by steatorrhea. Pain and steatorrhea. Chain of lakes appearance. Cystic hygroma, most common indication of surgery is. Cystic hygroma, most common indication of surgery is cosmetic disfigurement. Cystic hygroma, most common location is posterior triangle of neck. Second common location is axilla. Third common location is inguinal region. Now this is a typical question. And fortunately for you guys, this is the last question. 56-year-old woman, a chronic smoker, is referred from orthopedics OPD with 6-month history of pain left shoulder radiating to her arm. Very good question. Copied from some book. Pain left shoulder radiating to her arm. Physical examination is unremarkable, including range of motion of left shoulder. That means there is no left shoulder dislocation. family history of diabetes, lung cancer, breast cancer. X-ray of the cervical spine and joint are unremarkable. On PA view and lateral chest radiograph, heart size is normal and lung fields are clear, with the exception of small opacity in the left apex. So this, when these two things they come together, pain left shoulder and small opacity, this is the clear cut case of non small cell carcinoma of the lungs. So this is a typical history. This is a typical history. Fine. Non small cell carcinoma of the lungs. Fine. So again, I'll be there in this group. So if you got any queries, if you got any doubt, and you feel like asking, you can always call me, you can always message me, we can always discuss the queries. Right? Fine. So I'll always be there in this group. You can always ask me any of your doubts in the surgery. Fine. I'll share this PPT. I'll share the PDF of today and yesterday also. Fine. But right now my next class is coming up. So time for me to say you bye bye, and hope to see you soon as postgraduate maybe. Right.